and I welcome you all to Delhi Orthopaedic Association postgraduate training program in shoulder. So this is series of webinars. We have already done 3 webinars. So this is the 4th one, and I welcome the expert faculty, Dr. B.B. Bhasin he's a senior consultant and a unit head and chief of arthroscopy. Dr. J. Maheshwari from Max Saket, he is in charge of shoulder. Dr. Raman Kant Agarwal, he is senior consultant upper limb surgery from Medanta. And Dr. Petit Gupta is senior consultant and sports medicine chief in Sir Gangaram Hospital. Dr. Shashank Mishra is a shoulder arthroscopy surgeon at Sir Gangaram Hospital. Dr. Sumit Arora, he is a professor in Maulana Azad Medical College. And I welcome Dr. Sharad Agarwal, Professor Lalit Mani from Delhi Orthopaedic Association, Dr. Hitesh Lal, Dr. Dhananjay, Dr. Vineet Arora. So I request Dr. Sharad Agarwal to say a few words about this webinar.
Thanks, Dr. Manish. Good evening, friends. I welcome you all to today's postgraduate teaching program of Delhi Orthopaedic Association. Today's theme is shoulder. My thanks to the learned faculty of shoulder surgeons led by Dr. Maheshwari, Dr. Raman Kant, Dr. Petit, Dr. Shashank, and Dr. Sumit for preparing this webinar at such a short notice. The webinar includes the basics which postgraduates are expected to know. Besides postgraduates, I'm sure it shall be a welcome revision for all of us. My special thanks to Dr. Manish, Dr. Shamsul Huda, Dr. Ashok Shyam for working hard behind the doors to make DOA webinars a huge success. Thank you.
Yeah, I have to add this webinar is basically supported by Ortho TV, and Dr. Ashok Shyam and Dr. Shamsul Huda are big support to it. Without them, this would have not been possible. So without wasting time, we'll go to the first speaker. I request Dr. Petit Gupta to speak on history and examination of shoulder joint. Dr. Petit.
Dr. Manish, is it visible?
Yeah, it is visible, and you're audible. You can start, sir.
Thank you so much, Dr. Manish, Dr. Sharad, and all DOA executive for organizing this wonderful webinar on shoulder. Today I'll be speaking on history and examination, which is the first basic thing for a PG when he is met with a case of a shoulder during the exam. So if you look at the shoulder, it is a complex joint, including humerus, glenoid, scapula, clavicle, and the soft tissue around. So we should not forget the soft tissue because they form the integral part of the shoulder joint. Now, when you're taking the history, the usual history which is to be taken in any other case, I'm not going to go through, but some of the points in history which are relevant for shoulder, I'll pick it up here, like age. Now, once you have the age of the patient, you start thinking, your thinking process should start that if the patient is less than 30 years of age, you are more likely to be encountering traumatic problems, instability more. And if somebody has age 45 plus, so we are going to look at more rotator cuff, frozen shoulder, and maybe 55 plus degenerative osteoarthritic conditions could be the cause. So the moment you have the age, you start thinking what could be the probable cause of the problem. Then also dominant hand, if it is involved, obviously is much more problematic with the patient. And also taking the work and sports history is important to understand how much the problem is affecting in day-to-day life of the person, because this will help us to formulate the treatment for him at a later time. And coming to the presenting complaints, the chief complaints. The chief complaints that we see the patient in our centers and our clinics are pain, swelling, clicking, weakness, stiffness, instability, of which pain is the most common thing, and it's almost associated with every other pathology like swelling or stiffness or instability. So pain is what we'll deal in more depth. So when we have the pain in shoulder, then we have to start thinking in the back of our mind that whether the pain is coming from the shoulder itself or it is coming from somewhere else, what we call as a referred pain. So there you can see the causes of pain coming from the neck, elbow, wrist, diaphragm, cardiac, and sometimes vascular. So you have to exclude them while you're doing your exam and your history. So from history to the exam. And if it is arising from the shoulder proper, then it could be non-traumatic cause, traumatic, or others. In others, you have to keep in mind, in the back of the mind, it could be entrapped nerve, it could be sick scapular syndrome, could be scapular dyskinesia, osteonecrosis of the head of the humerus. In traumatic, it could be acute or chronic. Again, could be soft tissue or bony. So all these things have to be kept in the back of the mind, and we have to exclude one or the other during our history and examination. Non-traumatic can be further classified into inflammatory, infective, metabolic, malignancy, degenerative, and the reasons of those are mentioned here. So this we'll have to try and segregate while we are doing our history. So what is important first and foremost is history of trauma. The moment we ask history of trauma, then we need to ascertain, is the trauma significant? If it is so, then it could be a traumatic pathology to soft tissue or bone. So we start thinking in those terms. Then the second common thing to find out is site of pain. Because as you see, as in the picture also, the moment the site of pain is at the anterior, slightly lateral and superior aspect of the arm, this is where the patient generally holds when there is a problem in shoulder, especially we have to start thinking in terms of rotator cuff issues. But if the pain was more anterior and coming down towards the front of the arm to the elbow, then we are looking possibly towards the biceps pathology, bicipital tendonitis and all those. But at the same time, if you see that the pain is in the top of the shoulder, then it is the AC joint area. So it could give us an idea that it is coming from AC joint. So our further history and further examination will go in that direction. Then the type of pain. Is it a dull continuous pain, or is it a sharp sudden pain? The dull continuous pain could be rotator cuff pathology, degenerative changes. Sudden sharp pain could be traumatic, especially after this history of trauma. It could be labral tear, it could be slap tear, things like that. Or is there a tingling sensation patient complains, and especially if there's radiation, then it is pointing towards the nerve pathology that we have to look at. Also, the severity of pain can sometimes give us an idea. We know that sudden severe pain is a common inflammatory pathology like supraspinatus, calcific tendonitis, which is the very painful condition where patient is neither able to sit or stand and is in problem. So severity also gives us an idea of which side we have to think about, which pathology, which particular part of the shoulder could be giving rise to the patient's problem. Then onset and duration of pain. So how did it start? As I said, was it after trauma? Then it's traumatic. If it's a gradual, insidious onset and a long duration, then we are looking at rotator cuff, maybe frozen shoulder, rotator cuff pathology. Or if it is pain at night, then it is more thinking in terms of it could be rotator cuff or it could be osteonecrosis. So this also gives us an idea which way we have to go. Radiation we talked about. If there's a radiation, then we have to look at the neck and the other neurological disorders which could have caused the nerve-related issues. Then the important thing is aggravating relieving factor as to when the pain becomes worse. So if the patient has pain in abduction of at about 90 to 100 degrees, we know it is because of impingement, possibly rotator cuff tendonitis, which is the cause of problem. But the same pain is at 140 or 160 degrees range, then we are looking at ACJ pathology. So the aggravating points can give us the cause of pain. Abduction external rotation possibly could be an instability causing pain. So we get an idea from this as to what pathology and where we are dealing with. Then lastly, we also need to know the progress of the pain. When it started, as it is getting progressively worse, but it's getting better. It's getting better, that means the pathology is settling down. But it's getting worse, that means something is ongoing process. So that also helps us in our thinking process. Similarly for swelling, all those headings we have to also revise in swelling. How did it start, the course, whether it is associated with stiffness, whether there is fever associated, is there slightest movement causing a problem along with swelling, then we think of infective pathology. It's associated with pain, slightest movement causing a lot of pain to the patient, it is bacterial infection, could be one differential diagnosis. But if it is insidious onset with low-grade fever, some loss of weight, we know that this is it could be towards tubercular pathology or a chronic pathology. Inflammatory pathology presents with pain, but not so much of fever, which may be moderate amount. So that also we have to factor in, as well as the metabolic causes of swelling. If there is a swelling, needless to say that we also have to do, if there's a localized swelling, the other examination of swelling, which is usual site, size, shape, surface, margin, consistency. So all those things have to be also done if we find swelling which is localized in and around the shoulder. Then looking at the stiffness, again, how did the stiffness start? The onset, duration, history of trauma. If there is no history of trauma, onset is slow and insidious, then again, we know we are looking at rotator cuff or frozen shoulder kind of a problem. But if there is a history of injury and an acute onset, then we know it's a traumatic cause, most probably rotator cuff, which is causing the issue, or any other bony pathology. So same kind of questioning, leading questions have to be asked here. Clicking is another complaint. Now, clicking, again with the history of injury and sharp sudden click or catch in the shoulder would actually point towards a labral tear, which is giving it. At the same time, if there is a gradual, slow growing pain and along with clicking at the back of the shoulder, we know that it could be snapping scapula, which could be doing it. So it gives us an idea which side to look at. Micro instability sometimes causes clicking with no history of injury. So that also has to be kept in mind. You have to have high suspicion of while we are looking at clicking or all these things. Then the patient may present with a frank instability, and this is more likely for postgraduates to come across because we see quite often in most of the clinics instability, and more than often they are picked up for exam because they give a good history. There is a lot of things to see. So when there's history of instability, the patient has come, it could be weakness and pain to complete frank dislocation. Here, history of trauma becomes very important, because we know if there is a significant history of trauma, then we classify that instability into traumatic. If there is no history or there's mild history of trauma, it could be a traumatic instability. And in instability, the index dislocation history is very important. When did it happen first, obviously, and how did it happen? Was it a significant trauma? Did you go to the hospital to get it reduced? It shows that there was definitely a dislocation. And how many dislocations since then is also important, because it gives you idea what kind of a pathology we will see in. We know there will be a labral tear, but what will be the level of tissue? If it is 10, 15, 20 dislocations, we know the quality of labral will be very poor, and also we may encounter the bony erosions also. So we need to investigate in those terms should somebody have 20 dislocation plus. Similarly, the position of discomfort as to what position does the shoulder cause problem to the patient. So typically we know the commonest instability is anterior, and in this place the patient has problem in abduction, external rotation, overhead, like playing badminton, or sleeping with the arm behind the head. So that's when it becomes uncomfortable. So that's anterior instability possibly. But at the same time, if the patient complains of pain when they're trying to reach in front and towards the left side of the body or across the body, then it points out toward the posterior labrum pathology. And if the patient has problem holding anything heavy while, like a suitcase or something heavy by the side of the body, then they could point towards the inferior labral pathology. So those things give us an idea what kind of instability we are looking at. And if the instability is there, then we also need to know, is there the same problem in the other joints? Is there a history of hyperlaxity and they're able to do tricks that they've been showing their friends and being able to do some crazy things with their body? So that would show hyperlaxity, if at all. Then the patient may present as weakness. Weakness, as I said, could also be a sign of instability. But if you look at weakness, then we are looking at more of the first thing that comes to mind. If there's a history of injury and following which there's a weakness, then we are looking at rotator cuff pathology, rotator cuff tear, which there's a typical history, like click, and since then the patient is not able to lift the arm up. But if there is no history of trauma and there are some signs of radiation or some tingling, then a neurological pathology should also be kept in mind. And if we think so, then we do a complete neurological examination. This leading, with this presenting complaints, we ask certain leading questions, find out how all these problems are affecting his life, his work at work, home, work, sports, how is it affected? So understand how much problem the patient is having. Also, the past treatment history, non-operative, operative, what he's already had, that will help us to plan further. Past medical history, diabetes, hyperlaxity, or any other medical problem. Family history, especially ligamentum laxity and diabetes mellitus. Now, with this in place, we have already stratified our causes of problem into, and hopefully we would have come down to 4 or 5 probable causes of the problem of the patient. Now, from here, we go to the examination of the shoulder. Now, here we'll try to narrow down to 1 or 2 causes, which are the cause of the problem of the patient. So, exam, just like any other part, goes into look, feel, move, and special tests. Same, this thing is used. So, we start with look, which is also called inspection. And that starts as soon as the patient walks into the clinic. How is he holding his upper limb? How is he holding his body? So that gives us some idea. Obviously, good history, and then a proper exposure for shoulder is required. The proper shoulder for shoulder examination, the exposure is from umbilicus above. The body of the patient should be bare so that we can see both sides of the shoulder, front and the back, and the neck. And obviously for the female patient, we need a lady chaperone who would do the needful cover for us to be able to do the shoulder exam. Then if this male patient, just observe him, how does he remove his shirt? Also gives you clue about pathology that we are dealing with. And then the inspection goes without saying from the front, side, back, and do not miss from the top. There is 1 or 2 things that you can pick up from the top which can be of importance. So in inspection, what we are trying to look at is the level of the shoulder, any deformity. We look at the skin for any scar, marks on the skin, which will tell us what has happened in past. Sinuses obviously tell us infective pathology, and wasting of muscle, and any other positive thing that we can see has to be noted down and compared to the other side to understand what is normal for the patient. From the front, we can see the sternum, the clavicle, the AC joint, shoulder for deformity, sulcus, any other wasting of muscles, deltoid, pectoral, bicep, scalene. From the side, the same thing is again inspected, and we look at the deltoid, we look at the scapula from the profile, high riding scapula, winging of scapula can be seen here also. And then we look at the pectoralis major in profile in front, and the neck for any other pathology of the neck that can be seen better on the side view. Once looking at the back, we reconfirm the shoulder level, which we had thought. Once we had seen in the front, we reconfirm. We look at the scapula for any abnormality. And wasting of infraspinatus is seen well from back, along with the parascapular and paraspinal muscles. And from the top, you can see the supraspinatus mainly, and any wasting of supraspinatus, which is very often there, can be well appreciated from the top. Once we have seen, then we go down to feeling, that is palpation. Have a routine. Could be anybody can formulate their own routine. This is just one example of a routine that we follow. Start from the spine of the scapula. So we start walking from the spine of the scapula, walk on to the acromion, ACJ, clavicle, ending up at sternum. Any pathology found anywhere, tenderness, then we dwell more into it. Otherwise, we go a low level below at subacromial space. Any tenderness, anterolateral in subacromial space could be rotator cuff related, which will give us an idea. Feeling the bony structures there, lesser tuberosity, greater tuberosity groove could give us an idea of bicipital tendonitis, and the coracoid process is to be felt for any pathology. Then the muscular and soft tissue tenderness. Along with that, the other finding of, as I said earlier, also swelling, scar, sinus has to be examined exactly how we would do in any general surgery or any other place. Not forget to look for sensory examination of the badge area, because very often some of the shoulder pathology are having association, and if it is missed, it may be, so do your badge area, put your hand and compare on the other side. And if there is any problem of sensory and you've been thinking in the from the history, then go ahead and do the dermatological, neurological examination, dermatomes and myotomes to be all checked. Then look at the movement in all the planes: forward flexion, extension, internal and external rotation by the side of the arm, by the side of the body, and arm at 90-degree flexion. Internal rotation will tell you about the capsular stiffness, GERD, and all those things can be picked up there. And then abduction, adduction. And both active and passive have to be taken because they give you a lot of information about the pathology. We've already talked, if there is a pain and restriction of movement during abduction at 90 to 100 degrees, we are looking at impingement. And if the same thing is at 150 degrees, then 160 degrees when we're looking at AC joint. If the active movement is much less and passive is much more, then we are looking at possibly rotator cuff tear. So there we have, when we have a tear in rotator cuff, patient is actively not able to abduct or forward flex, as compared passively, he or she may have full range of movement. So that gives us an idea about if active and passive is equal, likelihood is either if it is frozen shoulder or some other traumatic pathology. So this gives important information for us to go further. Then we come down to muscle power testing. Again, individual muscles have to be tested. There are two groups of muscle: the local rotator cuff muscle and the global muscles. So in the rotator cuff, we look at supraspinatus, which is done in this fashion, which is also called empty-can test. Patient abducts the arm with complete internal rotation in this plane of the scapula, and the examiner tries to resist that that movement. And if there is a pain, it signifies tendonitis. If there's a weakness, then it signifies loss of power. Then similarly in infraspinatus, ISP is done, arm by the side, and external rotation is done with the flexed elbow, and resistance is placed by the examiner. If there is pain or weakness, that's what we are looking for. Similarly, for the teres minor, we abduct the arm 90 degrees, elbow flex 90, and then the patient pushes the arm back, that is external rotation, resisted by the examiner, and if it causes pain or weakness, then it is positive. That is the three muscles. Then the left is subscap. Now in subscap, we have various many tests. This is for some reason gone on its own. This is the belly press test, but that you can do. But what we do recommend, the first test to do is the Gerber's test, which is the test wherein the patient's arm is internally rotated with the hand in the lumbar area, as you see there, and then the patient tries to lift the arm off the back while the examiner is trying to resist. Any pain or weakness is what one is looking for. We already saw the belly press test in the front, and there is another one, bear hugger. But you, if you have only one test, Gerber test, you can do well, that's good. But this is the bear hugger test, where you put the arm, the hand on the other shoulder, and the examiner tries to bring that palm off from the shoulder with the elbow and the wrist straight, and patient complaining pain or loss of power is what we are interested to know. Then we look at the other muscles. Pec major is when the patient actually presses into the iliac crest with both the wrist and hand on the iliac crest. You feel for the anterior fold of axilla, showing the pec major muscle. Biceps can be tested by speed test or Jagerson. In speed test, you keep the elbow straight and the arm is forward flexed, and the examiner resisting the arm movement, and any pain or weakness is what we're looking at. The Jagerson test is done in this fashion. You flex the elbow to 90 degrees and the patient is trying to supinate while the examiner is trying to resist. So any pain or weakness is showing a positive test. Biceps is forceful extension of the elbow against resistance can test the triceps, and an abduction of the arm against resistance gives the deltoid muscle. Then we look at some special tests for impingement from the history and examination. If we are thinking about impingement, then we do certain specific tests. We have already done the painful arc. We've done the power of muscles. Then we do certain specific tests, Hawkins test for impingement. Here, the patient is standing in front of the examiner. The patient's arm is forward flexed 90 degrees and the elbow flexed to 90. And then maintaining the arm at the same level, the examiner internally rotates, bringing the greater tuberosity under the acromion and rubbing the origin of the rotator cuff. And if there is any swelling or pain, the patient will complain of pain if there is any tendonitis. Similarly, the Neer's test can be done. Herein, the arm is internally rotated, and in the forward direction, it is lifted up all the way till about 170, 180 degrees. If there is pain at 90 degrees, that is rotator cuff tendonitis. And if it is 160, 70, it is AC joint. Then we also repeat the same test, supinating the arm. And if the pain goes away at 90 degrees, that shows that it is a mild tendonitis of rotator cuff. But AC joint pain will still persist even if you keep the palm supinated. So that gives us the information about rotator cuff. Then in instability, we need to find out what kind of instability it is and also confirm. As I said, 90% time you will come across anterior instability, so we should be able to examine it quite nicely. So the apprehension test could be done in the standing position or lying down. So in standing position, this is how it is done. The examiner stands behind the patient's arm is abducted 90 degree plus, and the elbow is flexed 90 degrees, and then an external rotation force is given, and if the patient winces or resists your movement, that shows that there is a forward push of the head of the humerus into the Bankart lesion, which patient tries to resist. It's positive test. Sometimes patient is having a lot of pain, and apprehension sometimes leads to actual dislocation in the clinic. And if we want to avoid, then we can do a test which can give the same information, giving less pain to the patient, that is Job's relocation test. This is done with the patient lying on the bed. As you see here, the patient is lying on the bed, shoulder is at the edge of the table, and what we do again, the same thing. We abduct the shoulder to 90 degree plus, and then elbow 90 degree flexion, and then external rotation is done. And there's a hand in front of the humerus, which is holding the humerus in. For a second, we lift the hand up, and the humerus moves forward. Patient has an apprehension, as you saw, and then you put the hand back to restabilize the shoulder so that the patient doesn't have a complete dislocation or serious pain, but you have got your information from that there is an unstable shoulder and anterior instability is there. If you have instability, then you also need to look at humerus translation. This generally we do under GA, which gives a better information, but even in an active patient you can do. So you hold and stabilize the scapula, and then with the other hand hold and stabilize the humerus, and then move the humerus forward and backward relative to scapula and see how much it moves. If it moves more than 2 quadrant, then it is lax, and if it's more than 3 quadrant, then it is almost unstable. So that gives us the humeral glide or humeral translation information. Then for posterior dislocation, we test the patient sitting or standing, as we're seeing in both. The forearm, the arm is forward flexed and adducted, and an axial force is applied on the humerus, stabilizing the back, and this puts the stresses on the posterior capsule and labrum, and if there is pain, then obviously it confirms the posterior labral pathology. And for the inferior labral pathology, we do the Hawkins test. Here, as you can see, the patient's arm is put on the examiner's shoulder, elbow straight, and at that stage, you put the downward force in the mid-arm region like this. And if there is any pathology here, inferiorly, the patient would complain of pain, and the information is received. Then if the multi-direction, you would see a sulcus sign, you will be able to insinuate your finger under the acromion easily, and you pull the humerus the arm down, and you can see those two dimples. As you see, this is a typical sulcus sign, sign of multidirectional instability. If you're faced with a situation, or in case of any instability, it is always a dictum that you look for hyperlaxity by doing a Baden score. And if you have a rotator cuff pathology, then you do the test for rotator cuff muscles, and you will get the idea about the power. But sometimes if it is there, this is what is called the drop arm test. The patient tries to lift the arm up, and they use a trick as she was able to do. And when you ask them to bring it down, they will again do a trick and then use the other arm support. So this is a typical drop arm test positive for a patient with rotator cuff tear. Then for AC joint, again, you do cross adduction test where the arm is forward flexed and adducted, and an axial force is applied. And as you adduct more and more elbow, a pain on the shoulder top is signifying ACJ involvement. Last slide to come, don't forget the scapula. Look from the back for scapular rhythm. So ask the patient to forward flex the arm from the 0 degrees and in abduction also, and look for the movement of the scapula. There may be an abnormal movement, or there may be a winging of scapula. So this gives you an idea that something is happening at the back, and that can be factored in when we are trying to understand what is going on and trying to come down to pathology, which is cause of the problem of the patient. So with this, we come down to the end of history and examination, which we have tried to cover all, which is basic. There are many tests described, but the commonest test and commonest thing that you should know and should at least have information we have tried to convey. I wish all the very best to all. Thank you. The patient hearing.
Thank you, Dr. Petit. Dr. Petit, can you hear me?
Yes, I can. Thank you.
This lecture has created a lot of questions from the audience. So I will combine two questions. One of the postgraduate want to ask you that what are the bony landmarks? Can you explain that how to palpate them? And they especially want to know about the greater tuberosity and the lesser tuberosity. Okay. How do you palpate the bony landmark? Can you just repeat that?
Yeah, so bony landmark, as I said, you have to have a routine how to go about. So we started from the spine of the scapula. So we start right at the medial border of the scapula with the spine. We go over the spine, and we reach the posterior angle, and then we come anteriorly onto the acromion, and then to the AC joint, and then the clavicle. Then we come back to the AC joint, and at the anterior tip of the acromion, you slide your hand down, and there you would find your greater tuberosity. And if you feel and go slightly medially, you will feel a groove, and then you will feel another tuberosity there, that is the lesser tuberosity. Now, in a lean and a good patient, you are able to very well feel it. I'm trying to feel mine here, and I'm able to feel it very clearly. But yes, in ladies and very muscular people, sometimes it can be difficult. So
Doctor, excuse me, can I?
Yes, Shashank, yes.
Dr. Petit, it might be easier if you stop sharing screen so that we can see you what you are doing.
Yeah, I should stop sharing. Should I completely stop sharing? Okay. Yeah.
Oh, I still see your, yeah, so maybe then we can see you. Yeah.
So as I was saying, we walk over the back of the spine of the scapula, coming to the angle and then coming anteriorly. Now this is the AC joint here that I'm feeling, and this is the tip of the acromion. And just slide your finger down, and here generally you will feel a bony structure, which is the greater tuberosity. And then if you go a little more medially, you would feel the lesser tuberosity, as Shashank is showing there. This spot is the lesser tuberosity, and in between there you will feel a small valley. You can feel here. If you just move from, as I'm moving my finger from medial to lateral, there is this, and sometimes even you can feel the tendon slipping under in a lean and thin patient. But obviously, yes, in a lady or in an obese patient or in a very muscular patient, it can be slightly difficult. But if you feel tenderness in that area, it gives you an idea we might be dealing with bicep pathology. And then we will go and do the speed test, the Yergerson test, see the biceps and examine the biceps further. Yes, Shashank, you saying something?
So just another indicator about the biceps. Usually the biceps pain is going all the way around the upper arm. It's not usually here. So that it gives an idea that the pain is in the biceps.
Yeah,
usually,
said,
and when you're doing it, it's always good to make a mark with your pen on the spine of the scapula. Then it will be easier for you to examine in the beginning.
Sure. As I said, if you have primarily pain in the front of the shoulder going down to the belly and towards the elbow, then you think about biceps pain. So that is that you get information from history also.
Dr.
Yes, Manish?
Petit, yes. How do you palpate for shoulder joint line?
Shoulder joint line. Now, this is something which is very difficult to palpate shoulder joint line, but you can be roughly in that area. Again, what you do is you look at the as I said, once you are going the greater tuberosity to the lesser tuberosity, if you go a little more medial anteriorly, just lateral to the coracoid, this is the area where roughly anterior joint line is. Similarly, for all of us, when we are doing injections to the joint, we follow the rule. We feel for the spine of the scapula. We go about 1.5 finger, that is 1.5 to 2 centimeter medial, and about 1 to 2 centimeter lower. And this is the area where posteriorly when you insinuate, and this is all generally even in the most muscular people, you will feel a little depression there. There's little fossa there, and when you push in there, this is where you would find your joint line.
And how do you basically elicit the anterior and posterior joint line tenderness? Like you explained about the joint line. Is
Yes.
the same place where you elicit the tenderness?
Yes, you would have to press the same place for joint line tenderness, though I don't know how relevant it is in our examination because we've got tests which can give us. But yes, if you were to look at joint line tenderness, these are the 2 points where I would press and palpate to generate pain or tenderness.
Dr. Pratik, what are the measurements that have to be taken during shoulder examination?
Yeah, so measurements are basically want to look at the height of the arm. So what you do is you look at the tip of the acromion and you take at the lateral epicondyle of the elbow from top to the bottom, and by a scale you can measure, and you do it from the other side. You try to measure the two, you get an idea whether there is any limb length discrepancy in the humeral side of the shoulder.
Dr. Pratik, what are the clinical points to consider for the deltoid contracture?
Clinical points to think of deltoid contracture. Now, there would be a history of deltoid when there's a deltoid contracture. There has been history of trauma, injection, following which the patient has problem in this area. There's pain. The difficulty in abducting the shoulder, the power would be low, and also you would see that the glenohumeral movement may be restricted. So all these things will give you an idea about deltoid contracture. And also you would see the scapula moving in that particular direction.
Dr. Pratik, what is the ruler test in neglected dislocation?
The ruler test is you put the ruler from the tip of the acromion and to the lateral epicondyle. If you are able to put that ruler, that means the humeral head is not in position, because normally the humeral head is there. You are not able to put a scale which will touch the acromion and the lateral epicondyle, because the humeral head pushes the shoulder, the ruler away. If you are able to put a ruler from the tip to the lateral epicondyle, that means the humeral head is not in its position.
Okay. Dr. Pratik, if the patient has thoracic outlet syndrome, how do you differentiate it from the other shoulder pathologies?
The thoracic outlet syndrome, there is a special test, separate test you do when you abduct the arm all the way up, and then you ask the patient to move the head or the chin towards that side. And if that causes the pain, then it could denote thoracic outlet syndrome. Also, you feel for the power of the pulse, the radial pulse in the arm by the side, and then gradually you take it up, and then you feel for the pulse at the abduction. If there is reduction in the volume of the pulse, that also gives you an idea that the patient may be having thoracic outlet syndrome.
Okay, Dr. Vineet, you have any questions for Dr. Prateek? Or any
Manish,
of the
may I?
Yes,
Yes,
sure.
just a minute.
Okay, Vineet, you want to speak first? Please go ahead.
Prateek, thanks for the nice presentation. I think most of the things were clear. Few of my PGs, they were requesting there is what is the difference between the anatomical movements around the anatomical axis and the true axis around the shoulder joint. And secondly, if the examiner asks about the movements, now which should be told first, like if it's a movement around the anatomical axis or movements around the true axis?
Anatomical axis. See, when the examiner is asking, we generally talk in the form of forward flexion and then the extension. Then you formulate the pathology also will guide whatever is present. So what we do is we ask for forward flexion and then see how far the patient is able to do. Then the extension, then the rotations, the external or internal rotation by the side, which is at the long axis of the humerus that we are looking at. And then at 90-degree abduction again. So that gives the idea about the capsular contracture, and then the abduction and the internal rotation and adduction both ways.
Okay, Dr. Shashank, you can ask your question and you also be ready with your presentation.
I'm ready. Okay. So a couple of things. I didn't want to interrupt Prateek regarding the questions. One is joint line tenderness. Somebody asked. I know why PGs are asking it. Usually examiners are fond of asking how to find out the joint line tenderness. Usually in shoulder, I don't know any condition where you actually need to. In ankle, in knees, joint line tenderness is very important. But I think Prateek already pointed out that joint line tenderness in shoulder is not very significant. So when you are asked this question in the exam, especially for PGs, they would want an answer. So you tell them that yes, we can palpate the joint more easily from the posterior aspect. You can do it, but it is difficult to do. And that's all the examiners want to ask. They want to know that you know something about it. But clinically speaking, it is not very relevant in most of the shoulder conditions. There might be some exceptions, but most of the times I have never looked for a joint line. I think Prateek would agree with me on that.
Yes, Shashank. That's why I said that if they ask and you have to answer, then that is the point. You take this, the angle of the acromion, of the spine, of the scapula, move 1.5 centimeter to 2 centimeter medial and inferior, and if you put your finger there, so roughly that is the area. And so you tell the examiner, I don't think so anybody would have
Second thing is about the abduction contracture. Somebody asked.
Deltoid contracture.
The deltoid contracture. Besides the history and everything, which Prateek already mentioned, injections, either a brachial palsy, old deltoid problem. There is one thing, and we saw this patient at the, I think we presented it in the ODOT meeting last time. These patients have, so the deltoid is contracted. So, but they want to bring the arm to the resting position. The moment they rest it, because of the scapulothoracic movement, the scapula at the back becomes prominent. So rather than looking for deltoid, look at the scapula. Because they want to get the arm close to their body, because that's the resting position. You cannot walk like this because of the abduction contracture. So they bring it down, and the moment they bring it down, the scapula at the back becomes very prominent. So that is a sign that abduction contracture is there. And then you cannot adduct it. Obviously, when there's a flexion deformity, you cannot extend. So when there's abduction deformity, you cannot adduct. So that is another thing.
Dr. Shashank? Sorry, I interrupted. Sorry.
Yeah.
No, you were telling something, Dr. Shashank. Point you were telling.
So that's about the deltoid contracture. And the third thing about thoracic outlet syndrome, again from the exam point of view. So examiners love to needle you, and they will ask you, okay, why this is not thoracic outlet syndrome? Dr. Prateek already mentioned hyperabduction test, but trust me, this is a very rare diagnosis. So all the examiners are wanting you to say is, sir, yes, I checked for a hyperabduction to look for radial pulse, but it is a very rare occurrence. It is not very common. I would not think of thoracic outlet syndrome in this patient. There are some cases. There is a cervical rape. It is very difficult to diagnose. but don't fall in the trap when the examiner asks you, okay, why it is not a thoracic outlet syndrome. I think that's it. Those are three things I needed to clarify.
Okay. And Dr. Shashank, please be ready with your presentation.
Manish,
You can share your screen. Yes, Dr. Sharad
is saying something.
I want to make what Dr. Vineet was saying about the movement at the shoulder. What probably he wants to bring out is that the scapula is not is at that angle from the body plane, about 15 to 20 degrees. So the patient, the examiner asks for movements. So whether to tell the movements in the plane of scapula or in the plane of the body.
Yeah, actually, this was the thing which I really wanted to know, because PGs were slightly confused about that.
Yeah, so the movement are in actually the plane of the body that we describe, but the tests that we do, like supraspinatus, we do, it is in the plane of the scapula. So like we do the Nears test, we do the empty can test, they're all in the scapular plane, which is 20 to 30 degrees to the body.
Dr. Prateek, how do you stabilize scapula while checking for the movements?
Sure. So as I showed in one of the pictures, let's suppose we are on the right side of the shoulder of the patient. So with your left hand, all the four fingers will be on the top of the scapula. So just above the spine of the scapula. So they will be holding the scapula from the top. And your thumb will be on the lateral edge of the scapula. So you grab hold of the shoulder, the scapula with your four fingers on the top of the spine and the thumb at the the lateral edge of the scapula, and that's how the scapula is now in your left hand. And then when the patient does the movement, or you do passively with your right hand holding the arm, then you can stabilize the scapula.
Okay, can I request Dr. Shashank Mishra to present his radiology PPT?
Okay, so we are going to talk about the shoulder radiology. Thank you, Manish and Ravi. This is going to be a very, very basic talk, and the smarter ones among you, I'm talking to the PGs, might know a few things. I might be emphasizing a little bit too much on some rather basic things, which I think you should know, and many of us even miss after 10 or 15 years of practice. So this is what, how we'll start with the x-rays. I will touch a little bit about CT scan, ultrasound, and then we'll go about on the MRI. Manish, feel free to tell me when you want me to stop. So that is the one thing I want you to first start. Absolute zero tolerance for incorrect view. You see, when you take an AP or a lateral view or an elbow, wrist, or a knee or an ankle, it is rather easy to take. But shoulder and the hip joint are the two joints which are not in the exactly transverse plane of the body. So to take a good AP or a lateral view of a pelvic, the hip joint or the shoulder joint is rather difficult. Most of the times we end up getting a bad views. So please, first of all, develop the zero tolerance attitude for getting a good AP and a lateral view of the shoulder. And we'll talk about it in a little bit detail in the next few slides. If by any chance, suppose you're practicing tomorrow, you have a small clinic, you can't get good x-rays, whatever the reason is, or in the institution it is not possible, get additional tests, either a CT scan or an MRI, depending on whatever is the requirement, but must get at least 2 correct views, and if you can't, get some additional tests done. The only exception being a shoulder dislocation. It may not be possible, the patient is in pain and you may not be able to get all the proper tests. All you need to find out is where there's an associated fracture with the dislocation. So just take whatever good AP and lateral view you can, and as long as you have ruled out any GT fracture, any surgical neck fracture, go ahead and reduce it and then do whatever you want later on. But except for this, I would suggest that please develop an attitude of zero tolerance for incorrect views of the shoulder. And what is the correct and incorrect view? This is what we're talking about. So we all know that every joint or every bone must be viewed from 2 directions, and these 2 directions should be perpendicular to each other. I think every PG knows, everybody, even MBBS guy knows about it, that there should be 2 perpendicular views. Then why am I talking about it? While AP view and lateral view is everybody knows that we need it. The problem is in the shoulder, it is very difficult to get. And most of the times, if you see, I tell you tomorrow, from tomorrow onwards, go to every shoulder patient you have seen operated in your OT or seen in your clinic, and look whether they had a good AP and a lateral view. Most of the time, what happens is in a trauma patient, we move the arm either in a little bit this direction or that direction, either internal rotation, external rotation, and that suffices for the two views. Usually it is the two rotations of the arm, that's it. So it's the AP and lateral view of the humerus. It is not the AP and lateral view of the shoulder. And what you need is an AP and lateral view of the shoulder. You don't need an AP and lateral view of the humerus. You will need that when you are fixing a shaft fracture of the humerus. You don't need the AP and lateral view of the humerus here. So what exactly is the AP and lateral view? A good true AP view of the humerus is like this. You get a good space. The glenoid is well overlapped, and what I mean by overlapping is there are two surfaces, as you would know, the anterior and the posterior. I'm going to talk about it. There's a humeral head and there's a good joint space in between. The coracoid is right there in the superior 1/3 of the joint. This is the coracoid, and the acromion right on the top. So this is a good true AP view, and I'm going to talk about it, why I'm calling it a true AP view. We never talk about a true AP view of the knee. We never talk about a true AP view of the ankle or the elbow. But why are we talking about a true AP view of the shoulder? In a little while. And you must have one lateral view. Most of the institutions can do a good axillary view or a bilateral view. So I was fortunate enough to work in an institution in Gangaram where Dr. Bhasin had already done the difficult part. He had already trained and really harassed them to get a good bilateral view. So by the time I came, everybody knew how a good bilateral view is done. In most of the institutions, bilateral view is not properly done. So you need to know how to get a good bilateral view, and I'm going to tell you why it is important. Of course, axillary view, most of us get it, and most of the cold cases, we get a reasonably good axillary lateral view in most of the patients. So this is how a true AP view is done, and this is how it is different. In a true AP view, the person is not standing flat against the wall. The shoulder is against the cassette here, but the person is tilted about 45 degrees. So it's like this to give the orientation. There's a gap between the opposite side and the cassette. So while doing this, you get an exact true AP profile of the glenohumeral joint. You can even do it in the lying down position if the patient cannot stand, like in this position. Basically, you need a true AP view. In a regular AP view, it's actually an AP view of the chest. It is not the AP view of the glenohumeral joint. So point number one after today's class, PG class, is differentiate between a true AP view and a regular AP view and learn how to get it done. Go to your radiology department, get it done yourself. So this is how a true AP view looks like. The anterior glenoid and the posterior glenoid look different. They are separate, and you know that this is not a good view. This is a good view. The anterior glenoid line and the posterior glenoid lines are perfectly overlapping. So you see good joint space there. And this is a true AP view. And this is exactly what I talked about. A lateral view, I think most of you would know. Axillary lateral view, you see a coracoid in the front, you see the acromion spine at the back, the glenoid, the humeral head. In most of the cold cases, it is rather easy to do it. We usually get it done in most of our institutions, not a problem. It helps you in seeing the anterior or posterior dislocation. This is the anterior dislocation. The humeral head has gone anteriorly. This is a posterior dislocation where the head has gone posteriorly. And how do I know it? Because this is the coracoid, the lighthouse of the shoulder joint. It tells me that this is the anterior and this is the posterior. So it tells me whether this is an anterior dislocation or a posterior dislocation. Similarly, if there is a GT fracture, you will see the GT going at the back or a LT going here. So you will know But what happens, and this is how you do it, I think it is not very difficult to do. I think most of you would know it. The only problem is, in some of the acute trauma patients, it is difficult to get an abduction. You need about 40 to 50 degrees of abduction. In proximal humerus fractures, where the patient is very painful, in frozen shoulder, where it is very painful, sometimes it is not easy to have the patient abduct to such a degree of abduction. And the other thing is, the camera needs to go way down. In most of the teaching institutions, you have got good machines and you may be able to do it. But tomorrow, when you go and have your own X-ray in your own clinic, most of the times the camera cannot go down all the way to the level of the table to get a good axillary view. Hence, you must know how to do a bilateral view. A bilateral view is so called because the scapula in this forms a Y. There's a glenoid in the center, there is a coracoid in the front, there's the spine of the scapula at the back, and all this makes a Y. And then the humeral head overlaps in exactly. So when it is dislocated anteriorly, that means towards the coracoid, you will see the head somewhere here. If it is dislocated posteriorly, you will see the head somewhere here. Yes, it cannot show you the GT fractures very easily because as you see, the GT is usually overlapped here. You cannot make out unless it is broadly, significantly displaced superiorly, then you can see it here. But generally speaking, it gives you a good idea to have a lateral view of the shoulder. And the good thing is you don't need any abduction, though it is a little difficult to do. And so this is how a posterior dislocation. So if you don't know what you're looking at, this joint looks reduced, but actually in this AP view, in this view, the humeral head has gone back, and that can be seen on the Y view. You see the glenoid here, and the humeral head has gone posteriorly. This is something usually missed. So if you have a good bilateral view, you will not miss it. So I've already talked about how a good bilateral view looks like. The scapula, the body makes the big stem of the Y, and then there are the two stems of the Y, the spinous process and the coracoid, and the humeral head right in the center. You also can see the AC joint, but I think that will be going into too much of detail. Let's miss that. Now, coming to your exams, especially for exams, some of the examiners really like to ask about the special views. Okay, what is a striker notch view? Okay, what is a mula view? What is a Bernaggio view? They were really important in those days when we didn't have CT scan or MRIs. Most of the times, the striker notch view or the west endpoint view or the Bernaggio view are rather difficult to do because we don't them too often. We don't get so many patients of doing it. So they are difficult to reproduce too. So it is important for you to know a couple of views like a Bernaggio view for instability, a Mula view, or a Y view, or there are about 30 different views. But if you can answer your examiner, yes, sir, I know the striker notch view is done for Hill-Sachs lesion, but in our institution, we rely more on CT scan to detect the glenoid or the humeral bone loss. In most of the cases, the examiners will let you go, but they just want to needle you, so you should know a little bit about it. So in my practice, and I think I can talk on behalf of a few of the people here, that CT scan is usually indicated in almost all displaced proximal humerus fractures. There are some old-time examiners which might be offended by that. Oh yeah, you're gonna get CT scan in everybody. But in clinical practice, in all displaced proximal humerus fractures, it is better to get CT scan done simply because I don't want to miss any fragment. Many a times, even in a big institution, if you're working there, it is difficult to get good AP lateral views, and you don't want to subject the patient to go back again and get so many views. So CT scan give much more information, and I think it is worth it. I would definitely get a CT scan done in a scapular fractures. As you know, scapula is a three-dimensional bone. It's not a longitudinal bone. The glenoid, the body, the coracoid, they're all over the place. You cannot see all of them in an AP or a lateral view. So for scapular fractures, I would always get a CT scan done. In shoulder replacements, yes, but I think Raman is going to talk about it in detail. In dislocations, yes, I get a CT scan rather than MRI. And whenever I'm not happy with 2 or 3 good X-rays, I'm not sure that they are good AP and lateral views. In my practice, I always try to get a CT scan just to make sure that I'm not missing on anything. So when you are dealing with proximal humerus fractures, I think these are the most common shoulder cases you see in your hospital, in your setting right now. Make sure that you are getting 2 perpendicular views of the shoulder, not humerus. And if you are treating a fracture conservatively, make sure that you always get serial X-rays. Even in innocent 2-part fractures, a fracture which may look good today may displace tomorrow. So please get serial X-rays. Ultrasound. This is something I get most of the questions after my shoulder imaging lecture in most of the conferences. It is good. Ultrasound is rather reliable when it is done by a good person. I don't get it done because I don't know how to see ultrasound images. I don't think most of us can read ultrasound images. In only last 10 years, I have learned to read MRI images. To read ultrasound images is very difficult. So unless you have a good ultrasonologist who you can rely on, who will pick up everything, and mainly in rotator cuff tear and biceps lesions, ultrasound is a good modality. If you have a good ultrasonologist, go ahead, get it done. But otherwise, in all soft tissue areas where I am not sure about my diagnosis, I go for MRI. So talking about MRI, so a couple of usual questions which I ask, I'm just trying to preempt them here. A good 1.5 Tesla is good enough, definitely not a 0.5 Tesla. In smaller cities of India, still we have a lot of MRIs, even in Delhi. We have a few MRIs which are 0.5 Tesla. I don't think they are good for a small joint like shoulder. They might be good for head or spine, but for shoulder, which is a rather small joint, in fact, even for a 1.5 Tesla, a local surface coil for the shoulder is more important. Let's not get into the nitty-gritty, but just for you to know that minimum must get a MRI shoulder of a 1.5 Tesla, but if there's an option, get a 3 Tesla MRI. When you're reading the shoulder MRI, always follow a fixed protocol. And what is that protocol? First of all, make a broad clinical diagnosis in your mind. And most of the shoulder problems can broadly be classified into these 3 problems. Either is the subacromial space problems like impingement, rotator cuff tears, partial, complete, small, medium, large. So first make sure in your mind, what are you dealing with? Are you dealing with the rotator cuff problems? Are you dealing with a different type of instability? Or something which doesn't fall into either of the 2? And then there are biceps lesions. Dr. Petit has already talked about all those problems. So what I'm trying to tell you here is that before you start reading MRI, in your mind, you must have some broad diagnosis, so that you can focus on that thing. If you don't have any clue what that patient has, it is very difficult to find a problem in the MRI unless it is rather obvious, like a massive rotator cuff tear or a head dislocated chronic dislocation. You will have difficulty reading the MRI. Have some basic diagnosis in your mind. Goes without saying that frozen shoulder, you don't need MRI to diagnose. There are some MRI findings in frozen shoulder, but trust me, a simple true AP and a bilateral or an axillary lateral view is good enough to diagnose a frozen shoulder. So I already talked about it. Don't read the report. Always follow a pattern. Make a diagnosis in your mind. Find out what are the coronal cuts. Read the coronal cuts first. Then go to the axial cuts, and in the end, go to the sagittal cuts. And if you always follow a routine, over the next 6 months to 1 year in your remaining PG time, within a year or so, you will be able to read it as good as you're reading your spine MRIs. I think most of the PGs are very good in reading spine MRIs, but not as much in shoulder. So what exactly is a coronal cut? Coronal cut is exactly the same as a true AP view of the shoulder. And I use this synonym just to remind me, CAP. The coronal cut goes anterior to posterior. So make a picture in your mind that you're looking at AP view of the shoulder, and every cut, the coronal cut, will take subsequent slices of the shoulder from anterior to posterior, about 20 or 30 slices. I'm going to show you about 5 or 6 because of the paucity of time. But if you just know that the coronal oblique cuts are basically the AP view of the shoulder, that will help you get oriented very easily. So just to get you started, this is the glenoid, this is the humeral head, rather easy to understand. This big belly, muscle belly here is the supraspinatus belly. It's coming here and attaching right there at the GT here. This is the superior labrum, the inferior labrum. These are the axillary vessels here. Usually you don't see much problems here. And then you see acromion or clavicle, depending on which cut or which slice you're taking. Among the first few interior cuts, if you recall your shoulder anatomy, you will see the coracoid. So look for the coracoid, and that will tell you that this is the anterior most cut. Now, when you see the coracoid, you can visualize in your mind that the humeral head should be somewhere here, the glenoid is somewhere here, and this is most probably the clavicle. Why it is clavicle? We'll come to that later. So this is the coracoid, and then we'll go from there. Just under the coracoid is the subscap. This is the subscap muscle coming from here and attaching to the LT. This is the deltoid, just to get you oriented. As you go a little further posteriorly, you will see less and less of this supraspinatus belly and more of the tendon. You see this tendon here, this black thing here is the tendon, this thing is the muscle. The dark black thing is the tendon attaching on the GT footprint. This is the footprint from here to here. It is about 1 centimeter beyond or lateral to the articular margin. The articular cartilage ends here and it attaches somewhere here on the GT. So this is what you call the footprint, where the supraspinatus or the rotator cuff muscle attaches. And as I said, this is the clavicle. You are going back with every subsequent cut. So you are just beginning to see the acromioclavicular joint. The acromion is just beginning to become visible and the clavicle is right here. As we go further back, somebody is yawning. Anyway, so as we go further back, you see more and more of acromion. You see the AC joint, and you see. So how do you make out? If I show you just this cut, how do you make out whether this is acromion or clavicle? This is something many times my fellow get confused. So clavicle is medial to the highest point of the head. This is the highest point of the head. Clavicle is always medial to the highest point of the head, whereas the acromion is either at the highest or lateral. So if you feel your shoulder, or if you look at the shoulder model, acromion is the lateral most structure on the roof of the shoulder, whereas clavicle is medial. So this is the acromion, and then of course there's a suprascapular notch. We'll not go into that. This is almost the most posterior cut, right at the back of the shoulder. After this, you will start seeing the posterior deltoid. And this is the infraspinatus tendon. You see the spine of the scapula. This is the acromion continuing as the spine of the scapula. This is the infraspinatus coming here and attaching. So there is a bit of about 0.5 to 1 centimeter of infraspinatus, which you can see in the coronal cut. Infraspinatus is not a horizontal muscle coming behind the humeral head. It is a bit about 1 1 centimeter of it, or half centimeter of it, comes on top of the humeral head, merges with the supraspinatus tendon, and attaches on the greater tuberosity here. So if you see white signal here, you see that means the tear is extending into the infraspinatus. And I'm going back to there. If you see a white signal here, that means it's the tear of the supraspinatus. After that, you go to the axial cuts, and just to get you oriented, try to remember an axillary lateral view. The axial cuts of the MRI are just like the axial cuts of the axillary view, and they go superior to inferior. So you start from the top of the shoulder, skin, clavicle, AC joint, acromion, and then tendon of the supraspinatus, and then so on and so forth. So this is what I was talking about. This is the spine of the scapula. This is the supraspinatus. This is all the deltoid all around, anterior, posterior, and the middle. And this is the supraspinatus belly and going into attaching to the greater tuberosity. As you go a little further down, you start seeing the coracoid. That again is the lighthouse of the shoulder. It tells you that you are in, this is the anterior part of the shoulder. And by corollary, all this is the posterior part. Why it is important is, once you know what is the anterior and what is the posterior on the axial cuts, you will be able to know where the Bankart lesion is. You will be able to see the subscap is in the interior, the posterior cuff is at the back. So it will get you oriented and help you know what structure is it. This is the glenoid, the coracoid, and the humeral head. As you go further down, you start seeing the anterior labrum. This is the glenoid, the anterior labrum, because there's a coracoid right there. You start seeing the subscap. You start seeing the infraspinatus coming here and attaching here. This is the infraspinatus tendon. This is the subscap tendon. And as you keep going further down, you see the lower and lower part of the glenoid and the humeral head. Make sure to see where the coracoid is. It is important in more than one way. Not only it tells you that this is the anterior and this is the posterior, it also tells you at what level of glenoid you are vis-a-vis supra-inferior. So coracoid, you stop seeing coracoid roughly about 3 o'clock position. Once you stop seeing coracoid, that means now you are in the area of the Bankart lesion. So this is the glenoid, this is the anterior labrum, and this anterior labrum, if there is a tearing here or a white signal here between the bone and this labrum, that means there's a tear of the Bankart. I will just go back just to tell you something. At this level, the lesion of the labrum is not important. It can be present normally. We call it sublabral recess, foramen, or whatever you may call it. But as you go further down, when the coracoid is not visible anymore and the labrum is attached, that means you rule out. Another way to see whether you are further or you're sufficient down is you can see the bicipital groove. This is the GT, this is the LT, and you see the biceps long head of the biceps in this. So once you see a good biceps groove, that means you are sufficiently down the glenoid and you can reasonably make a diagnosis that is a Bankart lesion or not. If this is torn, it is Bankart. If this is torn, it is called reverse Bankart. And sometimes you see these funny bony islands in the shoulder. Don't worry about it. You go further down, you see bicipital groove thinning out. It's becoming more and more shallow. And this is almost about 5 o'clock. So you're almost at the bottom end of the glenoid in this. And in this case, the labrum is securely attached to the glenoid. What is sagittal cuts important for? In most of the cases, sagittal cuts are only important to see the chronicity or how old the rotator cuff tear is. It tells you whether this rotator cuff tear is repairable or not. But just to keep it simple for you, this is the scapula, and again you need to know which is anterior and posterior. Is this the anterior, the coracoid, or this is the anterior? A very easy thing to remember is the scapula is anteverted. I think everybody knows that. So if the scapula is tilted this way, that means this is anterior and this is posterior. So anterior is which muscle? That is the subscap. Posterior is infraspinatus and teres, and on top is the supraspinatus. So this is the supraspinatus muscle belly. This is the infra and the teres muscle belly, and this is the subscapularis muscle belly. If these muscles are not occupying the entire space, they are shrunk. It's called the muscle atrophy, indicating a long-standing old chronic rotator cuff tear. I think that is enough at this level for you to understand that, okay, sagittal cuts, I will see to see whether the rotator cuff muscles are good belly or good strength or not. So just to complete it, you can also see the AC joint, and you can see the rotator cuff hood over the head. This is the spine, this is the acromion. So there's the posterior cuff, supraspinatus, and the anterior cuff. If this cuff, you see all white hair, here you can see the tendon. If you see all white hair, that means there is a massive rotator cuff tear involving all these muscles. So to conclude, I think all of us, you, me, whether you're a professor, you become a professor tomorrow, or you go into private practice, please make sure that you learn how to do 3 shoulder x-rays yourself. Most of the radiographers would not know the difference between an AP and a true AP view. They would know an axillary lateral view, but bilateral view is something most of the people don't know. So please make sure that you know how to do them yourself. If you are not able to get good views in a fracture situation, please get a CT scan done. I'm not saying that CT scan should be done in every patient, but learn to do the good shoulder x-rays. But if you are not doing, before you make a final decision for a treatment of a patient, get a CT scan done. For a frozen shoulder, please don't prescribe unnecessary investigations. They just are not required. Not only they are not required, they will throw you off the tangent. Most of the shoulders will have some partial cuff tear. They might have a slap lesion. And then you start thinking of something else. You get all confused. Oh, this is a slap tear. Now I need to do a surgery. For a frozen shoulder, only X-ray is enough. You don't need any other investigations. If you are dealing with a recurrent dislocation of the shoulder, go for a CT scan rather than MRI if the patient cannot afford a lot of tests. In rotator cuff tears, if you are taking them for surgery, please make sure that you look at sagittal sections to see whether the cuff is really repairable. Thank you very much.
Thank you, Dr. Shashank, for such a nice presentation. There are few questions for you. It will be a rapid fire session because we are, have less time. I request, meanwhile, Dr. Ramakant to be ready with his presentation. Now, Dr. Shashank, what should be the position of forearm while taking the AP view?
Okay, so there are many different publications which say, but I would say for a good true AP view, keep it either in the neutral rotation, about 5 to 10 degrees of external rotation.
Okay. Now it's a rather dangerous question in exam, but audience wants to know if view is not correct. Should we say that in exam that this is not a true AP view?
Okay. So, so number one, I think for the PGs, never be cocky with the examiner. Don't try to show something that you know and you want to show off your knowledge. All you can say is, sir, though it is not a true AP view of the shoulder, it's a regular AP view. I think based on this X-ray, these are the findings. So basically what you're trying to do is, you are telling him that you can't find fault with me if I miss some finding on this X-ray. And the moment you say that it is not a true AP view, the question will go towards the true AP view. And you know how to get a true AP view done. So the examiner will start talking about true AP view. So make sure that you don't act cocky in front of the examiner.
Okay. And Dr. Shashank, how do you position the patient for scapular Y view?
Okay, I wish I could show. I had a very good video, and actually Dr. Bhasin had asked me to make a video for that bilateral view. So if you want, I can. If there is time, at the end I can show you the video. It's about a 1 minute video how to do it.
Yeah, I will give you time at the end.
Yeah.
And I think there is another question related to it, that how do you say it is a correct scapular view, scapular Y view? I think that will take in the last only. Okay.
Okay. Okay.
And Dr. Ramankant, you are ready?
Yeah, I'm ready. Can you see my screen?
Yeah, Dr. Manish. Dr. Manish.
Yeah. Dr. Vineet, please go ahead.
Yeah. Dr. Shashank, very nice presentation. Yeah, things have become very quite clear to the PGs. You have mentioned that for frozen shoulder, only the X-rays are required, but you have not mentioned what will be finding in the X-ray to diagnose the frozen shoulder.
Very good question. Thank you, Vineet. So, what are the findings? I think everybody should know this. What are the findings of frozen shoulder on X-ray? No findings. The frozen shoulder Y view or an axillary view or a true AP view should look like an exactly normal shoulder, like your or mine shoulder. If you see the definition of frozen shoulder, it is restriction of shoulder motion in all directions with no radiological findings. So it is a purely clinical diagnosis. You get X-ray done just to rule out other problems. You don't get X-ray done to diagnose frozen shoulder. You do X-ray in frozen shoulder to rule out any osteoarthritis, any neglected dislocation or other things.
Yeah,
Okay.
Thank you very much. This
Now,
is what I wanted to carry the message to the students.
Yeah, that is a very good
Because
question.
otherwise,
Dr. Shashank, there is a
thank you.
question related to it. How do you differentiate between tuberculosis of shoulder and periarthritis radiologically?
This
Okay,
is the whole talk is on this.
Okay. Then we'll take. Okay, Ramankantji, you answer this question. And
This question will be answered in the talk, in the slide itself.
So please go ahead with your talk.
Okay, thank you, Manish. Thank you, Ravi.
So this is how I perceive the shoulder. I know the guys, you have gone through the history, clinical examination, and excellent demonstration of X-rays. But now you're in the clinic. The theoretical knowledge is over. So I will give you my perspective. How do I think of the problem, of a clinical problem, when the patient walks into my clinic? Now, I always consider shoulder to be a double-story house. So I know for sure that ground floor has got only glenohumeral joint and some spaces outside the glenohumeral joint. So what can happen in a glenohumeral joint is a frozen shoulder, arthritis, dislocations, and labral injuries. These 4 problems. Whereas in the first floor, you have an AC joint problem, bursitis, rotator cuff tendons, tears, and calcific tendonitis. So origin of diagnosis, you have to have the history, anatomy, function, and physical science. Of all, history is the most important, and Dr. Petit Gupta has shown it clearly. So what are the problems, clinical problems? There are some treatable problems, some diagnosable but untreatable problems, and some undiagnosable problems. A very good point which Dr. Shashank said. If you cannot think of a diagnosis, a provisional diagnosis, you cannot be ordering an MRI. Before ordering an MRI, you have to have some direction in which you are thinking a probable pathology lies. So these are the treatable problems. Stability, problem of stability, problem of motion, problem of smoothness, and problem of strength. This is the problem which we are going to deal with. The talk is frozen shoulder, periarthritis, or caries shoulder, or tuberculosis of the shoulder. So this involves problems of motion, which is frozen shoulder, or basically a stiff shoulder. When we come to problem of smoothness, impingement, arthritis come in problem of smoothness. So we are dealing with problem of motion or problem of smoothness here. So problem of smoothness, most common is impingement, but remember, if you find stiffness in your examination, there was a question which was asked, how do we do the glenohumeral or scapulothoracic movements? So all movements done by the patient, basically, which are active, are a combination of glenohumeral and scapulothoracic movements. You don't divide them into anything. But all passive movements which we elicit from the patient by stabilizing the scapula are all passive movements and primarily measure the glenohumeral movement. So to diagnose impingement, shoulder cannot be stiff. If shoulder is stiff in the terminal degrees of forward flexion, abduction, external rotation, internal rotation, you cannot diagnose impingement. That would be a false diagnosis. Glenohumeral impingement or subacromial impingement, you don't need to get into the detail because now the situation is a patient is having stiff shoulder. Shashank has shown the X-rays. So you order the relevant X-rays. This is an AP view, which is a capsuloid tilt because we want to see the subacromial space. This is a true AP view. We want to see the glenohumeral space. This is a supraspinatus outlet view, which is the superior half of the scapular outlet view, and the axillary view. So, as Shashank said, in frozen shoulder, active and passive, both movements restricted in all planes and they are equal. If passive movements are more and active are less, you are looking at rotator cuff tears. X-rays have to be normal. True AP and axillary. In this case, AP X-ray will not suffice. You have to have a true AP view because the only true differential of frozen shoulder is arthritis. So what kind of arthritis? There are 6 types of arthritis in the shoulder: primary OA, secondary OA, rheumatoid arthritis, arthritis following ABN, capsulorrhaphy arthritis, cuff tear arthropathy. And all can be diagnosed except for primary osteoarthritis and cuff tear arthropathy. They look the same on the X-ray, but all other else look different on the X-ray. There is one more condition: a patient can walk in your OPD with sudden loss of all the movements and acutely painful, and patient won't even allow you to touch himself. So this is acute calcific tendonitis. In this, it is painful and stiff shoulder, sudden onset, histories of last night, it strikes like gout. Patient will not allow any passive movements. X-ray may or may not be normal, and ultrasound is quick and diagnostic. So in stiff shoulder, we are talking of frozen shoulder now, and we are talking of primary frozen shoulder. It is absolutely different from a secondary frozen shoulder. Secondary frozen shoulder is something which is caused by some disease or surgery or trauma. Whereas primary frozen shoulder has got no history of injury and no history of surgery. These are the only 4 essential diagnostic criteria for frozen shoulder: no history of injury, no history of surgery, global restriction of active and passive movements in all the planes, and normal true AP and axillary views. If you find these 4 criteria and you are able to check the rotator cuff strength little bit in whatever position of abduction, you are almost sure that you are dealing with a frozen shoulder if the rotator cuff strength is reasonably okay and not painful. But if you find the strength testing of rotator cuff is painful or is weak, then you need to order an MRI because some rotator cuff tears do present with frozen shoulder as well. I'm not going to go into the detail, but I would like to say one thing for sure. This is the DOA club and your postgraduates. Periarthritis term was introduced by Dupley in 1872, stopped being used in the Western world in 1934, and we are 2020. I think we should stop using the term periarthritis loosely. There's nothing like periarthritis. We still call it a frozen shoulder now, back from adhesive capsulitis, but periarthritis is abundant, and we talk of frozen shoulder, primary or secondary. As I said, the essential criteria I've already covered, but imagine, this is the most important thing, normal true AP and axillary views, which is going to distinguish it with the arthritis. I'm not going to go into the detail, but this is one thing which I do. I'm coming to the exam now. What I do in my OPD, passive external rotation with arm in adduction is the first test I do. And I compare it on both the sides. I conduct it simultaneously on both the sides, and I compare. If I find that the external rotation with arm in adduction is normal, equal, painless on both sides, I rule out frozen shoulder, I rule out arthritis, I rule out locked posterior dislocation. So as you see in this X-ray, the joint space is decreased, glenohumeral joint space is decreased. There is osteophyte on the humeral as well as the glenoid side. The acromiohumeral space is totally gone. There is this white line under the acromion. There are cysts in the greater tuberosity area. This is definitely not a frozen shoulder, although patient will present as painful stiff shoulder. So I'm skipping the pathology and everything, theoretical part, because I've got only 10 minutes to do that. But this is the current thinking on frozen shoulder, cytokines and vascular endothelial proliferation. MMPs can have a role. Investigations, as Shashank said, X-rays, in doubtful cases, MRI. I would suggest MRI if you are in little bit of doubt. Remember, I have seen 2 patients with chondrosarcoma presenting as frozen shoulder. The third case was carcinoma esophagus and secondaries in the frozen shoulder, presented as frozen shoulder. So tumors can present as frozen shoulder, so beware. If you've got doubt and if you've got good quality X-rays, you can rule out everything fine. But if you don't have X-rays and you can't get the good quality X-ray, get an MRI scan. Freezing phase, management of frozen shoulder is easy. Freezing phase, only glenohumeral injection and stretches. Frozen phase, stretches. Thawing phase, again stretches. So this is how the X-ray of a frozen shoulder looks like. A true AP view, absolutely normal proximal humerus, absolutely normal glenoid, absolutely normal acromion and AC joint arch. There's nothing wrong in the X-ray. Whereas this is a classical primary osteoarthritis. I see many patients of arthritis being labeled as tuberculosis, which is wrong. Tuberculosis may be common in India, but believe me, osteoarthritis is as common. So this is a classical arthritis. You see the sclerosis there. You don't see that in tuberculosis. Now, this is the most important part of the presentation today, of the lecture today. This is the most important slide. And you see a big osteophyte there. You don't find these osteophytes in tuberculosis. You find cysts there. You find joint space reduction. You don't find sclerosis. You find total osteoporosis. You find erosions there. So there's a lot of difference between an X-ray of an arthritis and the tuberculous arthritis. But rheumatoid arthritis can actually fool you, and you need to be pretty sure that whether it is rheumatoid arthritis or tuberculous arthritis, both will present with the same kind of radiological picture. Both can have a CVC deranged and ESR and CRP raised. So it is important that in such cases, you will have to go further in investigation to prove your diagnosis. So tuberculous shoulder is only 1 to 3% of the extrapulmonary skeletal tuberculosis. And this is common form is caries sicca, which is a dry form. Rarely you find swelling, abscess, and sinus. Uncommon to present in stage of synovitis. And rest of the things are as for any other osteoarticular tuberculosis. Clear in children. Clinical features as explained along with the general TB symptoms, constitutional symptoms, radiological chest X-ray, shoulder X-ray, CT, MRI, bone scan, Montu test, and biopsy, arthroscopic or open biopsy is the mainstay. And I'll come to it. Why do we need to achieve a biopsy and a tissue diagnosis before we subject the patient to such a diagnosis and ask him to take medicines for 12 to 18 months? Culture is possible and can be obtained even in 2 to 3 weeks and maybe in 8 weeks. The best one is the 8 weeks, but still we can take the biopsy, put the patient onto antitubercular treatment and send for these cultures as well. MRI is extremely sensitive in the early detection of osteomyelitis, especially contrast enhanced MRIs. So if in doubt, get the MRI. Synovial fluid aspiration is insufficient to make a diagnosis. There are a lot of differential diagnoses. I have dealt with this. Septic arthritis, you will find swelling, increased temperature, warmth. Frozen shoulder, you will not find anything clinically. Impingement, we have discussed. Osteoarthritis, we have discussed. Synovial osteochondromatosis, I will come to the couple of cases. PVNS, gout and hemophilic arthropathy, you will have something in the history. Anti-tubercular drugs, preferably after culture sensitivity and histopathology due to emergence of MDR and strains. 33% of patients are having multi-drug resistance. So that is why you should obtain a tissue diagnosis. Arthrodesis probably may be a choice in a patient, but preferably avoided. So this is a case of my patient who presented to me in synovitis stage with extensive synovitis, rice bodies, and relatively all the movements were preserved. So clinico-radiological impression is not the diagnosis. MRI and imaging, no gospel truth. Adequate cultures are possible. Are we heading to pre-antibiotic era? We need to be sure before instituting the treatment. A patient with frozen shoulder and concomitant pulmonary tuberculosis may be misdiagnosed as Calcific. This is one of my patients again, 34 years old. And he presented to me 4 years after onset of symptoms. That was the condition. That was his axillary view. You can see all the bone is eroded. There's cavity formed, joint space is reduced, big cysts, even in the axillary view, even on the glenoid side. Scapular lateral view, which showed me that it is primarily glenohumeral. The subacromial space seemed to be okay. That was his MRI, the axial cut. His glenoid and head of the humerus both were destroyed. That was the glenoid. So that is the end of my presentation. But I can, I did this arthroscopic debridement and biopsy in this patient, and he achieved, at the moment, he has a full range of movement after immediate rehab. But I did send him to the tuberculosis expert so that I don't manage his anti-tubercular treatment. Take the help of your medical colleagues, but of course you should know the latest regime of tuberculosis. I'm sorry, I don't know the latest regime of tuberculosis, but I treated him with the old regime of 4 drugs for 2 months and then 2 drugs for further 12 months. Any questions?
Yes, Dr. Raman Khan.
Yeah.
There's a question for you that what are the clinical points except history you inquire in Calcific?
Like constitutional symptoms, history of cuff for pulmonary tuberculosis, extrapulmonary tuberculosis, if I'm suspecting a Calcific.
Okay.
Yeah. Lymph nodes in clinical exam, you will check for the lymph nodes.
Okay.
Supraclavicular, axillary lymph nodes.
Okay. So, any other question for Dr. Raman Khan from the panel?
I have one question. Can I?
Yes,
Can I run this
sure,
video?
Sure. Yeah, you can run this video. You can run this video.
Tell me which shoulder. This is the same gentleman I showed you the X-rays. He's got full range of movement now. But that was aggressive debridement at presentation, putting him onto the ATT and completing the course and extensive rehab. Yeah, what's the question?
So, Raman, one thing which has always confused me is while making a diagnosis for a frozen shoulder is a patient with diabetes mellitus or a uncontrolled thyroid or uncontrolled diabetes. Would you call that a primary frozen shoulder or a secondary frozen shoulder?
No, that will be a primary frozen shoulder. It will not be a secondary. Diabetes, thyroid, and all the associations are associations. They will still remain. It will.
Two remarks for the PGs. I think Raman made this point very clear, and I just want to re-emphasize it, that passive ER for diagnosing frozen shoulder. I think Dr. Maheshwari calls it the no external rotation test. You can call it whatever you want, but it cannot be overemphasized that if a patient has a passive external rotation, if you can rotate the patient externally on your own, then it is not a frozen shoulder. Please don't diagnose a frozen shoulder. All of us get so many patients sent to us by being labeled as frozen shoulder, that it is one last thing is, before we go to the next presentation, is stiff shoulder in frozen shoulder. Stiff shoulder is a finding for various reasons, for osteoarthritis, because of rotator cuff tear, because of any other immobilized shoulder, you can have a stiff shoulder. But a frozen shoulder is a diagnosis. It has to be there in absence of any injury and any radiological finding. I think that is something you need to remember for your clinics and your exams. Over
Can
to you.
I start with the next talk?
Yes, yes. Dr. Maheshwari, please. Raman, I think you are doing the rotator cuff. You can finish it off now, because we have. Okay, finish it off. Finish it off.
So this is how your rotator cuff is. So we've removed the acromion. That's the clavicle, and that's the lateral part of the acromion. But you see the coracoacromial ligament going to the coracoid, and you are looking at the shoulder right as like you will look at the shoulder in the lateral view. You will see this subscapularis, coracohumeral ligament. You will see the supraspinatus. But can you identify anything between supra and infra? This is actually infraspinatus. Supraspinatus is only less than a centimeter, 8 millimeter insertion. And this is you are driving alone, you are backseat, the columnar trash. This is although I said no history of injury, but this is the ligament responsible for frozen shoulder. But there are 3 joints, acromioclavicular, sternoclavicular, and glenohumeral, and 2 articulations, subacromial and scapulothoracic are articulations. We must understand this slide. So rotator cuff is actually a misnomer. It is a compressor cuff. It compresses the ball of the humerus, which is 2.5 times bigger than the glenoid. It creates a horizontal force couple from subscapularis, which gives 60% power to the joint, to infraspinatus and supraspinatus and teres minor, which only give 40% power. External rotators are still 40%. Internal rotators subscap is 60%, but they balance out. They hug the ball of the humerus like this and compress it into the glenoid, and they also produce some rotations. But their primary work is to maintain the stability of the shoulder joint. Why do we need to know about the rotator cuff? It's the most common shoulder problem. Of all the problems of the shoulder, rotator cuff pathology is the most common. Its prevalence at 50 years of age, 10 to 11% of normal population is having frozen shoulder. At 80 years of age, 36%. Asymptomatic tears are twice as common. So you can think that in faculty, at least 1 or 2 people will be having it. At least me, I might be having it because I'm 50 plus. Why do we need to know about them? Untreated tears progress in size, become chronic and retracted, and become irreparable. Symptoms worsen and function deteriorates. Fatty degeneration destroys the muscle bellies. Risk of developing rotator cuff tear arthritis. That's the importance of rotator cuff. History, I'm not going to bore you with this history. Let's go back to this history. History of trauma may or may not be present. Traumatic cuff injury can happen to any age, right from 20s to 80s. Non-traumatic cuff tear is commonly present in the 5th decade onwards. Symptoms, pain is the most common symptom. Night pain is usually present. Weakness may be present alone along with pain, and difficulty in ADLs. So this is my protocol of examining a rotator cuff suspected pathology. First of all, we need to examine the C-spine. We need to carry out the neurological examination of the extremity to rule out brachial plexus Petit. If rule out stiffness, as I said, impingement cannot be diagnosed with stiffness, and if rotator cuff tear presents with stiffness, that will be a challenge to diagnose clinically. Look for the signs of biceps disease. I only rely on speeds test, but you must know the ergason as well. I don't rely much on the biceps tenderness. For me, tenderness in any pathology of the shoulder, except for septic arthritis or joint line tenderness, is probably insignificant. Signs of ACJ disease, that's the only joint I rely on tenderness in the acromioclavicular joint. And lastly, all the 4 rotator cuff muscles need to be tested. And Dr. Petit Gupta showed excellent videos. But there is little bit of ambiguity when you want to perform these tests. For supraspinatus, I would rely only on the empty can test. You don't need to bother about any other test. Infraspinatus, the resisted external rotation by elbow by side. For teres minor, I would again go back to the resisted external rotation elbow by side along with hornblower sign. And subscapularis, I may on Napoleon belly press test because Gerber liftoff is too painful. Any pathology, the bursa gets stretched and pain is induced. So you already know this. This is infraspinatus. And this is the most important clinical sign to detect teres minor dysfunction is external rotation lag sign at 40 degrees. So I do the strength testing, this test at 40 degrees and also at neutral as Dr. Pratik Gupta showed. At 0 degree, it tells me about the infraspinatus. At 40 degrees, it tells me about the teres minor as well. This is the belly press, this is the bear hug, and this is the Gerber liftoff. Now we come to the subscapularis. This little bit liftoff test is the most sensitive and specific test. There is no doubt about that. It's just about the practical implication of this test because people find it very difficult, even in bursitis or cuff disease, to reach their back and try to attempt this test because it's painful. This is one of the patients. She's got a subscapularis tear. As you see the MRI, she can't reach her back. Painful, she stops there. Where to do the liftoff in this? And I would like you to concentrate on, see how does she do the belly press. So ask the patient to press the tummy with hands and then ask her to bring the elbow forward so that wrist is straight. If the wrist is not straight, that's a positive sign of subscapularis insufficiency. So look at the wrist, whether the patient is able to bring the elbow in line with the wrist, yes or no. If the elbow stays behind the coronal plane of the body, then you can further grade this test. But this is the test I rely on. In patients who are able to reach the back, there is the lift-off, which is the best test anyway. So this is the ER lag on the right side. Look at the face. She's doing it, but with pain. This is again an indication that it is not. She's a determined lady, but she's painful. She's unable to lift. Unable to lift. See the flailness in her. She's not able to lift it properly. There's no question of strength testing in this situation. Atrophy Shashank is already checked, but you have to look at the T1 weighted oblique sagittal cut, where the scapula appears Y-shaped. And this has to be the most lateral cut of the Y shape, not the medial, the most lateral cut. As soon as you start, when you're going from lateral to medial, as soon as you start looking at the scapula, as soon as it appears Y, that's the first cut, that cut should be looked at. Obviously, infraspinatus atrophy, but now there's a question for the postgraduates, and I won't tell the answer. Why it is visible in the infraspinatus and not in the supraspinatus? What to look for in X-ray? True AP view, shape of acromion, and I do it in neutral rotation. Somebody asked this question, what should be the position of arm? I keep the arm in neutral rotation or in external rotation during the true AP view. Lateral view will tell me about the presence of spur. Axillary view will tell me static anterior subluxation in cases of chronic tears. And Zenka view will tell me the AC joint pathology. So X-rays are very important. MRI or no MRI, I need to have the X-rays. Furthermore, during the presentation, I'll tell you, this is the progressive cuff disease. So a normal X-ray. But see, the cuff has been rubbing against the acromion. It has developed a sclerosis. Now, the lateral spur are more dangerous than the medial ones. You see the medial eyebrow as well in this case. And you see little bit of AC joint of the supraspinatus coming there, and forming there. And this is deltoid, because I see this subdeltoid bursa white thing there. I know the superior surface of the cuff is intact, and this is the mainly the junction of the musculotendinous unit, which is gone. That denotes a complete tear. Tendon is retracted. It's not only retracted, I see the lamination of the tendon there, but I know the tendon. But whatever you see in the AP view, and as Shashank emphasized time and again, you have to have the orthogonal views, even in the MRI. And this is the orthogonal view. So where do I see the cuff tear? The most lateral view of the sagittal cut. As soon as I go beyond the skin and deltoid, that's the cuff, the most lateral cut. In fact, if you see the 5 MRI images in the topmost of the film, I think the second or third cut itself should reveal the rotator cuff, because that's the beginning of the greater tuberosity. And as I go medially, this is the lowermost figure is the lateral cut. From here I see the rotator cuff here. Here I rotator cuff here. Rotator cuff. I start seeing some tendon there. I start seeing some tendon here, and then tendon here under the acromion. So the lateral sagittal oblique cut is an important. Now I'm coming to a little bit of management. I just got only 10 minutes, so I have to rush. For impingement, no surgery, only posterior capsular stretches, NSAIDs, subacromial infiltration, scapular stabilizing exercises, because the scapula is usually not riding properly on the thoracic wall, so I need to improve the scapular kinematics. Partial tear, bursal-sided tears are more painful. They need surgery more often than the articular-sided tears. Articular-sided tears, less than 50% width of the greater tuberosity, which is around 16 to 17 millimeter. So less than 50%, you rehab. More than 50%, you take them down and repair. So this is one group, which is rotator cuff tendinitis and partial tears. Practically doesn't need surgery, except for bursal tears. Now there is group 2, full thickness tears with risk of irreversible changes. Now these are actual tears of any size, acute or chronic tears with recent functional loss, small and medium sized tears which have failed conservative treatment. Early intervention is needed in this group because they can sometimes rapidly deteriorate and progress to irreversible stage. So these are arthroscopic repair. I'm not going to go through the videos, but just the static images. That is how the impingement looks like. So otherwise, this is a shiny ligament, and there is nothing wrong there. So this is an undersurface of the acromion and the superior surface of the rotator cuff. Both are having kissing lesions by frayed cuff tissue, inflamed synovium around the acromion. This is an angry looking shoulder. This is impingement on both the acromial and the bursal side. I've taken the ligament down, and that's the spur. That's the original acromion, and that's actually the eyebrow sign, the medial spur, which we need to take, and that's the underlying impinged cuff. That's the articular-sided, smallest articular-sided tear, which looks like this. Cable is intact, and that's the crescent-shaped full thickness tear, and there it is, a repaired full thickness retracted tear. That's a large tear. You see the articular cartilage. As soon as the articular cartilage finishes, when we go inside the joint, the cuff has to insert there. You cannot see, and then you are looking at a partial tear. If you don't see anything, it's a complete tear. So I'm not going to go through the videos. They're not worth it for your time, but this is more important for you. So what is a massive cuff tear? Anything which is beyond 5 centimeters, involves 2 or more tendons, coronal length and sagittal width of more than 2 centimeters in MRI. These are 3 versions, but basically very, very large retracted tears, which are both more than 3 to 4 centimeters in AP and medial lateral extension. And what is the irreparability? You must know this. Chronic pseudo-paralysis without pain is irreparable. Something has to be done with that. Static and dynamic anterior subluxation is irreparable. Positive drop arm sign, ER lag sign, and Hornblower sign denote irreparability. AHI less than 7, this is debatable, but some people would say 5, some people would say 7. Gautelier stage 3 and 4, infraspinatus becomes irreparable. Means the failure rate is too high to repair. You can do anything, but failure rates are too high. And we can actually attach a central tendon retraction to glenoid in these criteria, and these things will form signs of irreparability. So MRI is the investigation of choice. CT arthrogram if you can't do the MRI. Now, another definition, pseudo-paralysis and pseudoparesis. Pseudo-paralysis means no active elevation, instead shoulder shrug, and there is an anterior superior escape. Pseudoparesis means some active painful elevation, but less than 90 degrees. So problems to be solved are many in these scenarios. This is a complex topic. I don't want to go there, but one of the techniques arthroscopically we use is margin convergence and try to convert a big tear into a small tear, which we can repair to the bone, single tear. But otherwise, there are many options. Just give me a sec, please. So more than 70 years of age, large massive tears, irreparable changes, we do partial repair, tendon transfers, graft, patches, superior capsular reconstruction, subacromial balloon spacers, and reverse shoulder replacement. Sorry about that, my computer is just giving me a bit of nap. So this is a paper by Burkhardt, but you don't need to go there because papers are individual studies and you don't need to bother about these studies. And this is what you are thinking now. What do I do? So many options. Believe us, even shoulder surgeons think about that. Just remember one thing, that this is current concepts for irreparable posterior superior cuff tears, no evidence for complex and expensive procedure, failure in short term in every procedure. So massive irreparable tears, reverse shoulder replacement gives predictable results, and you should know when not to repair and steer clear of the unpredictable options. Being aware and knowing how to do does not mean it will work. This is a true pseudoparalysis, anterior superior escape, and only one procedure will restore the balance, and that's the reverse shoulder replacement. But then there are such patients, if you see, the acromial distance is totally gone, tendon is totally retracted to the glenoid, there is no cuff, subscapularis is gone, infraspinatus is totally atrophic and white, subscapularis is black, infraspinatus white, no infraspinatus. But look at that. Look at our external rotation. So I would say focus on the patient. This is an algorithm which works well. Pain or disability not accepted. Patient insists for something to be done. You find tear is repairable. Functional demands are high, go and repair. You think functional demands low, you can still give steroid injection, and if patient still comes back, you can repair. If you think tear is irreparable, functional demands are high, shoulder replacement, functional demands low, again, palliative procedures like steroid injection and biceps tenotomy. Thank you.
Thank you, Dr. Raman Kag. I request Dr. Maheshwari to be ready with his presentation. Dr. Raman Kag, there is 2 questions from the audience. What is the difference between degenerative rotator cuff tear and rotator cuff arthropathy?
Arthropathy is
share out.
Dr.
Arthropathy is when
share.
yeah. Okay. So rotator cuff tear arthropathy is when there is arthritis because of the rotator cuff tear.
Okay.
Because the rotator cuff is torn, the upward pull of deltoid keeps on producing shearing forces. So 10% of rotator cuff tears develop rotator cuff tear arthropathy.
Okay. And when do you do arthroscopic repair and when do you do open repair for rotator cuff tear?
Well, I almost do arthroscopic repairs all the time now. But when I started, I used to do a mini open. But I have stopped doing that because it becomes easier for me arthroscopically. So I do arthroscopic repair all the time.
Okay. Dr. Maheshwari, can you go ahead with your presentation?
Manish,
we'll take questions.
Manish, can I please, if you
sure.
allow? Yeah.
Yes, one question, please.
No, not the question. I think he has done it, covered it very eloquently. Just a message for PGs. Raman is a established shoulder surgeon and he has all the options available for massive irreparable cuff tears. Please keep in mind that reverse shoulder arthroplasty is one of the options for massive cuff tears. Though examiners don't like to listen in the exam, and what happens usually is when you have a cuff tear and you have heard of reverse shoulder arthroplasty by Raman, the first thing that comes out of your mind, out of your mouth in the exam is reverse shoulder arthroplasty.
Only for pseudoparalysis.
And I totally get it. What you're saying
Only
is totally right. Just want to emphasize to students in the exam, only when the examiner really, okay, there is anything else you would like to do, there is anything else you would like to do, then only mention the reverse shoulder arthroplasty for a massive shoulder tears, irreparable tears. Be a little conservative about mentioning shoulder reverse arthroplasty in the exam. It is a very valid option. It is one of the options we all believe in. But for exam, there are a different set of answers you need to give. You should be aware of it, no doubt about it.
Can I start?
Yes, please.
Yes, sir, you can start, sir.
Am I audible?
Yes, sir.
Right.
You are.
I'm sure it is at the end of the day and it has been very long 2-hour session on something like shoulder. Must be very, very tiring. So I will just make it brief and simple, hopefully. Again, topic of shoulder arthroplasty is more theoretical for a postgraduate, but some ideas about the language that we generally talk. So the joint replacement scenario has been like this. In 80s, it was hip replacement, which was inherently a stable construct. Just put the socket, put the ball. Once it is gone in, more often than not, it will work whatever way the socket and ball may have been. So very, very forgiving. Mobility was there in all direction, but not that much, limited mobility. So basically, it is a very friendly joint for beginning orthopedic surgeons. That's why most people can do hip replacement very, very easily. How about knee replacement? It came in 90s, a little more tricky because not a stable joint like ball and socket here. The mobility was only in flexion extension. That is the grace. It was not very unstable joint, but we knew that we can make this joint stable in this one particular direction by adding something. For example, putting some kind of constraints. So stabilized. The knee replacement has stabilized, hip replacement has more or less stabilized, and now is the common surgery done as far as joint replacement is concerned is shoulder replacement. It is no inherent stability. It is flat on one side and round on one side. Everything has to be held properly by way of soft tissue balance, by way of muscular balance, by way of alignment. Otherwise, the shoulder is waiting to dislocate anytime. On the top of it, we need a lot of mobility. That is the function of the shoulder. Even if it is stable, and it cannot move in all direction, that shoulder arthroplasty is a failure. That's why shoulder arthroplasty is very tricky. You have to have a very good balance of stability as well as mobility. You want dono haath mein laddu. So how has shoulder replacement evolved? Let me quickly go through to make you understand why we are doing what we are doing. This was the first generation, what called monoblock. It had a round head of the humerus there. This will go into the humerus shaft, and this was just one piece. It was mostly used for trauma, more or less like a spacer. Remove the chura of, the multiple pieces of the upper head of humerus, just shove it in with cement, without cement. It used to mostly act like a spacer, not much function. And we very quickly realized that this one piece cannot do everywhere. So it has to be a second generation, which means they detach the head and the shaft like this. So you can put the shaft in, then you can put head the kind you like. It can be different sizes, it can be different width, and you can try to be a little bit smarter about balancing this shoulder better, because now you have a choice of doing something during surgery on the table. That was second generation. Again, it worked better than first generation, but there were problems. Till this new very dynamic concept came about 20 years back, what is called third generation of anatomical prosthesis. Now this is what one has to understand. This is where we are today. So shoulder is not like a lollipop that there is a humerus and there is this thing sitting on the top of the humerus like this. It's not like that. It has different inclination, tilted like this, retroversion, offset, and head size. Now these four things vary at the upper end of the humerus from patient to patient, and variation is really wide. That's why if you put one size in every patient, it doesn't work. It either loses on stability or loses on control or loses on, pain relief. Something happens if everything is not matched. That's why today's anatomical prosthesis, which takes care of all these four aspects, it replaces what you remove and the way it was. You have to remove whatever was there in the body and remove it the way it was for that particular person. That is the trick. That is the problem why a shoulder replacement is a little bit more difficult surgery, because you have to match with that patient everything. And from this understanding started the journey of success of shoulder arthroplasty, and that's what we are traveling. Let me right in the beginning tell about the basic indications. As per books, primary osteoarthritis is the most common indication of replacing the shoulder. Rheumatoid becomes another one, then fractures, and rarely avascular necrosis and cuff tear arthropathy. Unfortunately, in our country, I think fractures are almost equal, if not more than even primary osteoarthritis, because our old people accept everything. All these category of people have no problem, even if they're handicapped, their family support, blah, blah, blah. But fracture is something devastating, particularly even in young people of 50, 60 years of age. That's where most often shoulder replacement is done in this country, which is different from most of the other countries, where aging population and osteo and rheumatoid are more common. How about non-arthroplasty option? One has always to think about these options before you even talk about arthroplasty. You can give steroid injection like in any other osteoarthritic shoulder. Hyaluronidase has no role in my practice, nowhere, not even in the knee, and definitely not in the shoulder. Physiotherapy can be done, but I've seen n number of patients where physiotherapy makes it worse. So very often these patients are erroneously treated as frozen shoulder. Patient goes for physiotherapy. Oh, doctor, physiotherapy के बाद तो और भी खराब हो गया, दर्द और भी बढ़ गया, and that raises an alarm that something is wrong. And arthroscopic surgery can be tried in selected cases. If this doesn't work, then you come down to shoulder replacement. So what are the types of shoulder replacement? Since the PG class, I'll keep it very basic. There are two types basically, anatomical and reverse, and I'll come to what it means. Anatomical means the way our anatomy is. You have a socket and you have a ball, like the shoulder is. It is like that. You replace the socket, replace the ball. That is called anatomical shoulder arthroplasty, the way natural body is. You can do it hemi, which means remove only the upper part of the humerus and replace it with a ball. Now that can be done in three different ways. First is called resurfacing, where you don't even remove the ball of the head. You just grind it, resurface it, ream it, and put a kind of a cap. That is called resurfacing. Now the similar to the cousin of resurfacing is what is called Stemless Hemi, where you remove the head part, just chop it off. The upper humerus is as it is, just chop off the ball part of the head and put a artificial thing. So this is just reaming and capping more or less. Head is still there. In this, there is no head. Just chop off the head, put an artificial head on top of that cut portion. The next is stemmed hemi, which means once you have removed the head, don't just put the head on top of the cut portion, ream into the medullary canal, and this head carries a stem with it. So most of the fixation goes through the stem. So these are three different types of hemiarthroplasty. You're only replacing or doing something to the upper end of the humerus and nothing to the glenoid. That's why it is called hemiarthroplasty. If you do total shoulder replacement, which means you replace the glenoid as well as the head of the humerus, it is called total shoulder replacement. You are replacing both the components. Now this can again be stemless, which means it is a stemless thing. You are replacing that either of these three methods. Most commonly this, and sometimes this hardly ever, but you are only replacing the head without using the stem. Or you can do a stemmed total shoulder, something like this, where you put a stem, put a head, and also replace the glenoid. So in anatomical way, either partial or full. If partial, these are three types. If full, these are the two types. Then we come to reverse shoulder, and I'll come to that, what it means. It's a very funny concept, and I'm sure for some of the postgraduates, the youngsters, it may not be very clear what it means. And then there is an in-between called platform stem, where you can put a stem in the medullary canal, and on top of the stem, you can put either of these two. You can do a anatomical as well as reverse. That stem works for both. So that is another new development, that you can use a platform stem depending on what you want to do on the table. This is an example of the type of shoulder prosthesis available. This is resurfacing. This is just a cap on top of the head. Head has not been removed. Now here the head has been removed, and we have replaced it with a ball with a stem. In the stemless, it is only this part. There's no stem here. Only this part is replaced. And this is hemi because nothing has been done to glenoid. Nothing has been done to glenoid here. This is a total shoulder replacement, where you can see these two white dots show that the plastic is there, which is not visible on the X-ray, but the glenoid is replaced by a kind of a shallow plastic sheet, which is called glenoid prosthesis. And on the humerus side, you replace the humerus with a stemmed implant. This is what is called reverse shoulder replacement, where you reversed everything. Why it is called reverse? Because the humerus head, or so-called ball, has come to the glenoid side, and the cup has come to the humerus side. So as against this, where the ball is on the humerus side, in this the ball is on the glenoid side. That's why it is called reverse. And there's a very nice kind of logic and biomechanical logic of doing this rather funny, stupid looking operation, but it is one of the most successful and a favorite operation these. It's like putting somebody upside down, and it works. So what is a reverse shoulder? I would just like to give a little idea about that. And for this, you have to understand biomechanics of the shoulder joint. A little bit. I'll not go into too much detail. The basic biomechanics of the shoulder is this. The head has to be centered on the glenoid by something, and then only your deltoid, etc. can work. It's called force couple. One part of the muscles, which are rotator cuff muscles, will put the head back to the glenoid, hold it there, kind of compress it there, and then only these other muscles can lift it. If these muscles are not there, these muscles cannot produce the movement that we want to do. And I'll give you this example. If this guy is to lift this stair from there, he has to lift it. Unless he supports it on his leg here, from his feet, he cannot put force this, and it will never lift. If he removes his foot from here and he tries to lift, the CD will come on this side. So if you want to produce this movement, there has to be a control from here. That means stabilizing, and then the power working. It is something similar that happens in the shoulder. And that's how the normal shoulder replacement works. That the stabilizers are here, the rotator cuff muscles, and the deltoid is here. As soon as the stabilizer compress this to the glenoid, the deltoid can work and the shoulder movements happen. Now imagine a scenario when this cuff is not there. For example, the cuff is torn. What will happen? As I told you, the deltoid will pull it up. Now this is going to happen. Once the cuff is torn and your deltoid contracts, there is nothing to keep There's nothing to keep this head in the ground, in the glenoid, and it will move up like this. And you cannot have any movement. It will be like lifting it up and down without any functional movement. And that's what happens when there is a rotator cuff injury and what is called, pseudo-paralysis, etc. Because there's no way this biomechanics of the shoulder is functioning and it cannot function. So what do we do then? You can do this. You want to center the joint. So you can have a glenoid with an extra support, which will not let the head go that side. That's a very simple logical option. And if the head does not go there, if this head does not move in that direction, this deltoid will be functional because now the head is in the center place. It is where it should be. This shelf is doing the job of rotator cuff. It's a very simple logical option, but it doesn't work that way. Why? Because center of the rotation is here. And when you do this, all the force goes in this shelf. And what it does is over a period of time, by repeated hitting on the shelf, it makes this loose. So it did not work. This method was tried early in the beginning, but it did not work because the glenoid will get loose very fast because this head is trying to support on this. And as you know, it cannot take the support. The implant bone junction will loosen up. No difficulty in understanding there because so much force, all the force is going from here to here. It will make it loose. So the next idea came, why not make some change that this is the part which gets loose, the glenoid, so-called glenoid. Why not do something that the center of rotation is shifted here? That means whenever you move the arm, the center of rotation is right at the base of the glenoid. That means there's no forces, no shear forces on the glenoid. And how can you do it? It's not possible. So the idea came, why not reverse? That means put this glenosphere here, and now when this arm moves, the center of rotation is here. This is the arc on which it is moving, but the center of rotation is here. So the chances of this loosening at this glenoid or so-called glenoid and bone junction have become less because there is no shear force at this center of location, which was here because of a big arm. As you know, the liver, how the liver works. Longer is the liver, more is the force here. Now there's no liver here. Right at the base is the center of rotation. So by changing the glenosphere, like making it reverse, it was a very intelligent move that even without a rotator cuff, now this head can move around this glenosphere without creating any loosening here because the center rotation is right there. That's the philosophy of how reverse shoulder works. Now, how long do these last? Just for your knowledge, there are a number of studies that shoulder replacement lasts more than 15 years in 90% of cases, and even reverse lasts more than 10 years. So we prefer reverse in anybody more than 65, 70 minimum. This can be done at earlier age because if it fails, you can always do reverse in those cases. But these are 10 to 15 years result operation these days, and these are fairly old reports where in 85% of cases, these joint replacement have lasted for 15 years. I'm sure it is 20 years now. So reverse or shoulder replacement is nearly as successful as any other replacement of the body. We are just going there. Just the last slide. How do you decide which shoulder replacement will you do in a particular patient? The key deciding point, as I told you, is rotator cuff. If cuff is okay or is repairable, if it is not so, there's no cuff, it is not repairable, you cannot do an anatomical shoulder, you have to do a reverse shoulder. So first thing that we examine is the cuff okay? If cuff is okay or is repairable, then yes, it is possible to do total shoulder. We may not be able to requiring a reverse shoulder, and then we decide the age of the patient. If the age of the patient is less than 70, glenoid is normal more or less, and only head is not damaged, you can do resurfacing. It's just arthritis, cartilage is gone, but glenoid is reasonably okay, head is reasonably not damaged, you can do resurfacing, you can do hemiarthroplasty, stemless. Suppose the glenoid is okay, but head is badly damaged. Then you cannot do resurfacing, then you have to do hemi of some kind or even total replacement if the glenoid is not okay. Suppose the patient is older. In that patient, usually both are damaged, head as well as glenoid, and one would more often than not prefer doing a total replacement or a hemi replacement depending on requirement of that person. But if the head is damaged and the glenoid is also damaged, more and more people are shifting in a 70 plus. One operation which is very predictable is reverse shoulder replacement. So reverse shoulder replacement somehow has become so popular because its success rate is quite high, that if person is more than 70 and there's any doubt about his rotator cuff, any doubt about his shape of the glenoid, any doubt about bone stock, then one has a tendency to move to reverse. But if the patient is active, everything is fine, you can also do total shoulder replacement. I think that chart gives an idea about how do we decide about which one to do in which patient based on damage of the cuff, based on age, based on damage to the glenoid, and also damage to the head. On these four bases, we can have this flow chart to understand which one is required in a particular patient. Thank you for your kind attention.
Thank you, Dr. Maheshwari. I request Dr. Sumit to be ready with his presentation. Any question for Dr. Maheshwari till his Dr. Sumit is preparing his PPT? Any questions?
Hello, Maheshwari sir.
Yeah.
Hello, Maheshwari sir. Dr. Vineet here.
Bolo Vineet.
Sir, students just want to know, is there any absolute indication for reverse shoulder?
Yes, absolute indication is rotator cuff deficiency. If rotator cuff cannot be improved by any means, there is no other replacement that you can do except reverse shoulder replacement. That is the only absolute indication.
Right. And absolute contraindication?
Absolute contraindication would be possibly the bone stock is very poor.
Or deltoid palsy, or deltoid is not working.
Deltoid is not working. Deltoid is the key muscle for moving reverse shoulder. So deltoid is not working. That would be an absolute contraindication.
Right, sir. Thank you very much, sir.
Thank you. Bye-bye.
Okay, and I think there are a couple of questions more, but I think we finish it off with Dr. Sumit's presentation and then we take questions at the end.
Yeah, that's okay.
Dr. Sumit, please, you can start.
Am I audible?
Yes, you are audible. We can see your PPT also. Yeah.
All the students must be tired by now. So I will briefly cover the basics of shoulder arthroscopy. So this is as you must be knowing that it is the second most common orthopedic procedure and the second to only knee arthroscopic meniscectomies. And in comparison to the open ones, it gives comprehensive view of the intra-articular pathology. And it is minimally invasive and has the potential for the rapid rehabilitation. So I will be covering my talk under these heads. To start with, the indications of shoulder arthroscopy. So all the students must be assisting their seniors for various indications. So common beings are the rotator cuff tear, labral tears, and the subacromial impingement. And the rare ones will be adhesive capsulitis, proximal biceps pathology, loose bodies, and the degenerative arthritis. So we will briefly cover the OT setup and the instruments. So everyone must have seen all the basic instruments that are available in all the hospitals. These are the special ones, especially designed for shoulder. These are shoulder pump, RF probe. These are the arthroscopic burrs and the shaver blades. So this is the arthroscopic probe. Wissinger rod, also known as switching stick, is a tissue liberator. A similar instrument is the rasp, the basket punch, the tissue grasper. This is the arthroscopic knot pusher, arthroscopic knot cutter, suture manipulator, and crochet hook. So any of these instruments may be shown to you in your exam and you may need to identify those. So various sorts of cannulas are available. These are the fully threaded or the fully ribbed cannulas. These are the partially ribbed cannulas. Majority of the time ribbed cannulas are used when there is some intra-articular manipulation is there, or if the surgery involves away from the joint, like in rotator cuff, these sorts of self-retaining cannulas may be required. So various suture passing instruments may be required, like this is the spectrum suture passing instrument, is available for left and right side of the shoulder joint. This is the suture leaders, where the oblong hole is there to lead the suture from the soft tissues. And these are the special suture passing instrument known as bird beak or arthropliers. especially if the rotator interval is short and is narrow in cases of arthroscopic Bankart repair, and you intend to do the procedure with single anterior portal. This is a very valuable instrument. So this is a special instrument known as Elite Suture Passer, and is very much helpful for arthroscopic rotator cuff surgeries. And these are the various makes of different makes, like Champion from the Striker and True Pass or the First Pass from the Smith & Nephew. So from this talk, this will be the three important things that every postgraduate student must be aware of. And to start with, one must learn the proper positioning of the patient in the OT setup. So two common positions that you must have seen are the modified lateral position and the beach chair position. Initially, surgeons used to use this dead lateral sort of lateral position, where they used to have problems with the anterior access to the joint. So a modified lateral position was invented, and it is a sort of floppy lateral position where 30 to 40 degree modified lateral patient is placed, so that the glenoid axis is placed parallel to the floor, and the surgeon would have ample space anteriorly for the instrumentation. So this is the OT setup for the modified lateral position, where the traction has been applied, and apart from traction there is a little bit of forward flexion. Apart from traction, some sort of lateral sling traction may be applied to distend the joint, especially if the shoulder pump facility is not available. This is another position which is called beach chair position. The patient is seated in this position under anesthesia, and a bolster is placed in the scapular region, and one must ensure that the acromion is approximately parallel to the ground. So the operated limb may be held by the assistant, or special holding devices like McConnell, Spider or Trimanos are available in various setups. So one must be aware of various advantages and disadvantages of each one of these positions, but it is a matter of is a matter of surgeon's preference and your learning in which hospital you are working. Whichever position you are comfortable with and you have learned the position, you have the orientation with, you must use in your clinical practice. However, there are certain discrete advantages and disadvantages of each one of these procedures. For example, the traction may be applied in lateral decubitus position, and it increases the joint space and accentuates the labral tears, right? However, beach chair position is considered to be upright position, and it is anatomical in comparison to the non-anatomical orientation of the lateral decubitus position. So, however, the beach chair position has certainly got this major drawback in the terms of hypotension or bradycardia leading to cerebral hypoperfusion. So one must be very much aware of this sort of disadvantage, and which is not there with the lateral decubitus position. So if the patient is being planned for shoulder arthroscopy under regional anesthesia, the patient is not likely to tolerate this procedure in lateral decubitus, and beach chair will be preferred. So if one is using traction in lateral decubitus position, traction is being used, one should be cautious about the possibility of neurovascular injuries and the possibilities of slight misplacement of the usual anatomical landmarks. So the next important point is portal placement that every postgraduate student should be aware of. For that, one must be aware of the surface landmarks or the anatomy. This is the first and foremost before making any portal. But apart from this proper anatomy knowledge, one must be aware of the proper working angle intended for, required for that procedure, right? So if you are using a correct surface landmark and putting the cannula in a wrong working angle, you are likely to have problems and difficulty in performing the surgery. So you need to be good in using a proper working angle of the cannula. So one must use some sort of a spinal needle or IV cannula needle for this placement. So these are the general anatomical consideration before making any portal. So as far as anterior part is concerned, one must remain lateral to the tip of coracoid process, because to avoid any sort of neurovascular injuries like brachial plexus and axillary artery is lying inferior-medial to that. Likewise, inferiorly, one must stay up and away from the 6 o'clock position. Likewise, for the medial side, at the base of the scapular spine, one must be careful with the navigator portal into the joint. So the further few slides, we will use a common term that is known as rotator interval, and many a times postgraduate students are not aware of this term and they got confused while the talk is being given. So this is the anatomical, when you are doing some dissection sort of thing in cadaver. So anatomically, the rotator interval is called when it is bounded superiorly by the anterior border of the supraspinatus, inferiorly by the superior border of the subscapularis muscle, and base is formed by the base of the coracoid process medially. However, if you see arthroscopic images, majority of the time for practical purposes, superiorly you can see a long head of biceps, and inferiorly you see the upper border of the subscapularis muscle, and base is formed by the anterior glenoid margin during the arthroscopy. So the star is showing the place of arthroscopic rotator interval. These are the various portals, and postgraduate students should not get confused with so many portals, and they should rather focus on workhorse portals that are: number one, this is the posterior portal, these are the anterior portals, and these are the lateral portals. And the location of the lateral portal majority of the time is determined by the intended procedure. There are few unusual portals like this. This is the Navier portal, and like this is a portal of Wilmington. But they should not be confused with so many portals, and they rather should focus on workhorse portals. So this is the superior view of how the shoulder looks during the arthroscopy part. This is the acromion, and this is the clavicle, and this is the coracoid portion. This is the workhorse portal posteriorly. These are the lateral ones, and these are the anterior ones. So how are you? This is the most important portal in shoulder arthroscopy, because the scope is inserted through this portal, and viewing portal is this only. So it is very important you place this portal at a correct location, which is the 2 to 3 centimeter inferior and 1 to 2 centimeter medial to the posterolateral corner of the acromion. And it passes through the belly of the infraspinatus majority of the time, right? So one must be aware of the structures like a posterior humeral circumflex artery and the axillary nerve, which lies 7 to 8 centimeter inferior to the posterior border of the acromion. So while placing the skin incision is placed at the area which is described here, and blunt tip Wissinger rod is placed inside in the direction of ipsilateral coracoid process. So a PG student will majority of the time falter or will be scared of progressing ahead. So it is a common learning that can be told just now, that if the PG student is pointing the tip of the Wissinger rod to some bony structure, he can ask his assistant to rotate the arm internally and externally. If the tip of the Wissinger rod is palpating the rotations, then probably the tip is there on the humeral head side, and if it is not palpating any movement, then it is probably on the glenoid side, and the likely point of entry inside the capsule will be somewhere in between that. So likewise, the anterior portal, they are located 1 to 2 centimeter inferior-medial to the anterolateral acromion border, and just in front of the laterally over the coracoid process. One must not go beneath it or medial to it, because the musculocutaneous nerve is located 3 centimeter inferior and just medial to the tip of the coracoid process. So there are two methods of making anterior portal. One is outside in technique and other is inside out technique. So this is the most preferred technique, which is known as outside in technique. A spinal needle is introduced at the intended entry point, and its trajectory inside the joint is seen, and it must enter inside the joint just above the upper border of the subscapularis muscle, and a beautiful rotator interval is depicted here. But, few surgeons are there who prefer inside out technique, where the camera is the scope is advanced to the intended anterior portal, and the scope is withdrawn, and the Visinga rod is advanced through this sleeve, and here the established portal is secured by cannula, and the Visinga rod may be switched with a scope to look for. Majority of the surgeon prefer outside in technique because it is more reliable and safe. So a lateral portal, one must be aware of the lateral orientation line. This is the clavicle, this is the scapula, and this is the acromioclavicular joint line. So at the posterior border of the acromioclavicular joint line, if we draw a tangential towards the lateral side, this is known as lateral orientation line. And the lateral portion, lateral portal, majority of the time will lie somewhere in this, and 2 to 3 centimeter distal to the lateral border of the acromia. This is made. At times, we may need to convert the arthroscopic procedure into mini open one. So the same incision may be utilized for the same. Axillary nerve is located 5 centimeter beyond the acromion, so one must be very careful about it. So now the important another thing is the things to be seen in the diagnostic round of the shoulder, and all the PGs should pay special attention to this, because unless they know all the structures, they are likely to miss some arthroscopic finding, which may hamper the result later on. So a diagnostic round is based on the 2-circle approach based on the Southern California Orthopaedic Institute, and first circle is comprised of glenoid aspect, and the other circle is comprised of humeral aspect. So glenoid aspect of the joint is examined using the first 9 positions, and the humeral aspect of the joint is examined from the position number 10 to 13. 14 is reserved for subacromial space. So I am attaching figures, representative figures from the each position, and postgraduate students must pay attention to this. The position number 1 is meant for superior labrum and the biceps attachment for to see any tear, instability, or the slap lesion. So this is the superior labrum, this is the glenoid. You can see a cannula inside the joint through the anterior portal, and this is a long head of biceps attaching here. Position number 2 is meant for the long head of the biceps tendon. One must probe it to look for any pathology or the subluxation. So a probe is seen to check the mobility of the lateral head of the biceps. Position number 3 is meant for superior glenohumeral ligament, and one must be aware of all the possible anatomical variations of this ligament. It is seen just below the long head of the biceps tendon here. And the position 4 is meant for middle glenohumeral ligament, and one must also be well versed with all the anatomical variations of the middle glenohumeral ligament. So this is a beautiful picture of rotator interval, and the subscapularis muscle is seen here, and overlapping this is the middle glenohumeral ligament. At times there are a common anatomical variation of the middle glenohumeral ligament is the Buford complex, in which the anterior labrum is absent and middle glenohumeral ligament is like a cord. So one must not confuse this thing with any other structure. Position number 5 is meant for subscapularis tendon. So here the subscapularis tendon is marked here for you to depict. If one is having some difficulty in visualizing, so one must ask the assistant to internally and externally rotate the arm, and subscapularis muscle will be seen quite clearly. So there is another method to clearly see the subscapularis muscle is ask the assistant to posteriorly sublux the humeral head, and during this movement the subscapularis will stand out quite nicely. Position number 6 is for the anterior-inferior labrum and anterior-inferior glenohumeral ligament pathologies like Bankart lesion and the Elpsa lesion. So here the anterior labrum is seen quite nicely attached to the glenoid rim, and here this is seen detached from the rim, depicting the Bankart lesion.
Dr. Sumit, can you wrap up because we are falling short of time?
So I am just 2-3 slides.
Yeah, sure.
Right. So position number 7 is meant for axillary pouch and anterior-inferior and posterior glenohumeral ligament. This is the space, common space for the loose bodies. So one must look out here. 8 is meant for posterior labrum, Bennett lesion, and the reverse Bankart lesion. So this is the posterior labrum is seen. One must be careful not to withdraw the scope too much, otherwise it may fall out of the joint. Position number 9 is the last thing for the glenoid side, is the posterior superior labrum. This is depicted here. And 10 is meant for the here the shoulder, the humerus head round starts. It is meant for the supraspinatus attachment to the greater tuberosity of the shoulder, like this. So the position number 11 is there for the infraspinatus attachment to GT, and 12 is to see the bare area of the humerus. Bare area of the humerus is there in between the border of the articular surface and the joint capsule, whereas it must be differentiated by the Hill-Sachs lesion, which impinges onto the articular cartilage as well. So these are the last two positions that one must be aware of. 13 is for the capsule, to look for the adhesive capsulitis, fibrinous synovitis, Hegel and reverse Hegel lesions. So the rotation of the arm is very much important to diagnose Hegel and the reverse Hegel lesions arthroscopically. 14 position is meant for subacromial space. So one should be able to see the inferior acromion, thoracoacromial ligament, subacromial bursa, and the rotator cuff. Here the shaver blade is cleaning the subacromial bursa, and the rotator cuff will be depicted just below this. So few of the risks I have already talked about in the talk, and because of we are falling short of the time, so I conclude my talk here. If there is any question, please let me know.
Thank you, Dr. Sumit, for such a nice presentation. We have 5 or 7 minutes to take questions. So it's an open house now. Any faculty can ask questions in between themselves, and I will see that what are the audience questions, so we can start. Dr. Vineet, are you there? Dr. Vineet? Dr. Basin? Basin Saab has left.
Can we have the scapular view, how to take it?
Yes, yes. Dr. Shashank?
I noted that Dr. Vineet was mute.
Shashank sir?
Yes.
Lalit sir has one question for you. How to take the scapular Y view for the position for that?
Okay, so can I share the screen with
Yes.
permission from the moderator? Okay. I kept it ready. So first, let me show you. I think Lalit only asked one thing: how to know if it's a good Y lateral view. Is that what one question was?
Yeah.
Lalit.
Yeah.
Okay. So that is one. How exactly a Y view looks like? So I did cover it, but what you need, why it is called Y view is because the scapula makes a Y. This is the body of the scapula. This is the posterior border. This is the anterior border. So you must see an upright body of the scapula with anterior and posterior cortex. This is the spine of the scapula, and this is the acromion. In a well-done view, about 20% of the acromion should be at the level of the spine or behind it, whereas about rest of the acromion is in front of the spine of the scapula. Then this, many times when you get a Y view done, you will see this thing encroaching here. That's not because the AC joint is disrupted, but that is because it's not, the angle of the beam is not proper. And I'm going to show you how to take that view. So the acromion and clavicular joint should be clearly visible here in the Y view. And then this is the space, and then you can see the different types of Bigliani acromion, so on and so 1, 2, and 3. So to classify Bigliani acromion, you need this view to see whether it's the type 1, 2, or 3. Is that okay? Is everybody, any questions regarding this? How a good Y view looks like?
Yeah, that's good.
No, we need to know the position, how to keep the limb bend, what is the position of machine. That's
yes, I'm going there. Okay, now let's go to the video. So number one thing is you must do the you must mark the spine of the scapula. So that will tell you the spine of the scapula. You just make a mark with the pen initially where the spine of the scapula is. After that, turn the beam about 18 to 20 degrees caudal. And then the position of the patient is exactly opposite to the AP view. If you remember what I told about AP view, it is the patient is standing facing the beam. In this, the patient is standing with his back towards the beam, making about 30 to 40 degree angle to the cassette. Let's see this, how this happens. So beam about 18 to 20 degrees going down, patient with his back towards the beam and making about 30 degrees from the cassette. Let's see.
We can't see the video. Sir, video.
Oh, sorry. Oh, okay, wait.
It's not running.
It's not running? Just a minute.
Shashank, did you place this video in the PPT?
Yes.
Because it will work only in the PPT.
Oh, okay. Hey, just a minute.
You cannot play the video separately, so you have to put it in the PPT.
Okay, you can't see it now, right?
Now we can see.
Okay, let me start it from the beginning. Can you see it now?
Yeah.
So about 20 degrees of caudal angle of the beam. That is the cassette here. Patient standing with his back towards the beam. This is the spine of the scapula. The beam is coming, this line is made so that the X-ray beam is coming in the line of the scapula. And he's making about 30 to 40 degree angle with the cassette. Was that clear? Any questions?
Professor Manny,
Clear, sir.
it's okay?
Yeah, it's fine. I think the PGs need to practice this. Only then they will understand.
Okay.
That's very right.
Dr. Pratik, are you around? Dr.
Sir,
Pratik
stop
Gupta?
sharing your video.
Yes, I am there.
There is a question for you that how do you test, what are the tests for slap lesion?
Slap lesion, basically, essentially, you test as for the biceps. You do the same thing. You do what we'll call as O'Brien's test. In the O'Brien's test, you forward flex the shoulder and adduct it by 20 degrees. Just like you do for supraspinatus, you do for the empty can test, the same level of the shoulder, but it is adducted like so. If you can see my hand, about 20 degrees. And at that stage, you do the same thing as you do for empty can test. You press it down, and if there is pain elicited, that shows that there is a possibility of slap lesion. Then you also do biceps test, obviously, along with it. But this is one of the commonest tests that is done for a slap lesion. Okay. It's called O'Brien's test.
Yeah. Any questions from the faculty to any speaker?
I think we need to wrap up.
Yes. Now we need to wrap up. Dr. Shamsul?
Sir.
Yes, Dr. Shamsul, are you around?
Yes, sir. I'm here, sir.
So I'll take last few comments from Dr. Sharad. Before that, I will thank Dr. Shamsul and Dr. Ashok Sham for giving this opportunity for such a nice webinar, such an elaborate webinar that almost 3 hours people have studied shoulder. So I think there should be no problem in passing exams now. Dr. Sharad, your last comment.
Well, thank you, Dr. Manish. On behalf of Delhi Orthopaedic Association, I thank the eminent faculty for covering the subject of shoulder so lucidly, keeping in mind the requirements of postgraduate learning. As I said in the beginning, not only the postgraduates, it was a healthy revision for all of us.
Professor Manny, any want to share any thoughts, Professor Manny?
Just let me complete just one more line.
Yeah. Okay.
My sincere thanks to all delegates who joined the webinar and made it a success. Finally, my thanks again to Dr. Manish, Dr. Shamsul Hoda, and Dr. Shyam from Ortho TV for working hard to make the physical. Thank you.
Dr. Lalit Mani. Dr. Lalit Mani, can you hear us?
This net is not working, sir.
Mani, sir.
Dr. Lalit Mani. I think
sir.
he cannot hear us. So I thank the whole faculty, and it was a very success. But you know what has happened, that people are getting exhausted of webinars. So yeah, and actually spine and hip are more popular than shoulder. So our attendance is not matching spine and hip joint, but
I think Lalit is back.
Lalit, Professor Lalit Mani. Dr. Mani. I think he's not there. No problem.
But
So,
Manish, you
Yeah.
see, as Dr. Maheshwari also said, shoulder is not that many people are still into, and it is kind of gradually getting into the people's, liking as compared to spine, another thing where there's a lot of interest. So I think if you see any conference or any meeting of shoulder, the strengths can never match the other ones because of the limited area of, interest of the faculty as well as of the delegates.
okay, I think Professor Mani is back. Can you hear us, Dr. Mani?
Yeah.
Yeah, I wanted your last comment from you. You being the teacher at Maulana Azad. Yeah.
Are we still live?
Yeah, sir. We are
Yes.
live.
Yes, sir. Yes, sir. Realized.
So shoulder is not a very popular case in exam because PGs have been thinking it will not come in the exam. The common cases which come is maybe a strangled shoulder or a post-infective sequelae. But now as things are changing, painful and different type of shoulder cases have started coming in DNB. So I think it is high time that students start learning the special test and also start looking into the imaging in those things, because there are Viva tables which now have MRIs in them. So please start reading shoulder, the special test, and please start reading radiology and using more seriously.
Okay, thank you, Professor Mani. So we wrap up now. Thanks, Dr. Shamsul Huda, Dr. Ravi Chauhan, and Dr. Ashok Sham.
Thank
you,
you,
sir.
everyone. Bye. Have a good
Thank you,
night.
sir, for a
Take
wonderful
care.
webinar, sir.
Bye.
It was a real
Bye.
learning, sir. With your permission, I'm ending the live session, sir. Thank you, sir.
Okay.
Yes, sir. You're ending the live, sir. Yeah.
You are ending or you have ended?
Yes, I need, sir. The live session is ended.
Dr. Sharad, there is too much of knowledge today.
But I want to make one comment. These shoulder cases, they make good substantial number of cases in the orthopedic practice.
Yes.
A lot of patients you get of shoulder in the day-to-day clinical practice, and you got to be
Yes,
about it to the correct diagnosis. Otherwise, every shoulder is a shoulder. That's it.
So, Dr. Sharad, I think the next webinar will be on peripheral nerve injuries or peripheral nerve problems.
Next Thursday?
Peripheral nerve injuries and nerve problems.
Today?
Yeah, we'll tell you the date, because now lockdown will open after 17, so we have to reschedule it.
On next Wednesday. Manish, sir, next Wednesday we can do it.
Okay.
Dr. Manish, we'll talk about it before finalizing the date.
Okay. So good night, everyone.
Good night.
Good night, sir.
Thank you.
Good night, sir.
everyone.
I'm ending the meeting, sir.
Thanks,
Thank you,
Manish.
everybody. Good night.